Ladies and gentlemen, I would like to welcome all of you in this series of webinars I'm organizing with my team as treasurer of the World Federation of Neurosurgical Societies in collaboration with the Egyptian Society of Neurological Surgeons and the Continental Association of African Neurosurgical Societies, the CANS. I'm glad to tell you that we organized 55 webinars already. Many of them are educational WFNS symposium. Today is webinar 56, and I'm glad that this webinar is organized with the Spine Committee of the World Federation of Neurosurgical Societies, the WFNS. And I would like to thank Professor Salman Sharif, Chairman of the Spine Committee of the World Federation of Neurosurgical Societies, for the opportunity to have such wonderful collaboration. Let me welcome our keynote speakers. Professor Salman Sharif is Chairman of the Spine Committee of the World Federation of Neurosurgical Societies. He's Professor of Neurosurgery at Liniquat National Hospital and Medical College, Karachi, Pakistan. Professor Jyoti Parthiban, he was supposed to be among our speakers. Unfortunately, due to family problems, he will be replaced by Professor Sandeep Vishya. He is director of the Delhi Fortis Hospital in India. Professor Ian Vlok, he's Professor of Neurosurgery, Tygerberg Hospital and Medical College, Cape Town, South Africa. Professor Francisco Costa, he's affiliated to the Department of Neurosurgery, Fondazione International Neurological Institute, Milano, Italy. Professor Abdel Hafid Bajamel is professor at the Department of Neurosurgery, Erlangga University, Indonesia. Professor Nikolai Piv, he is professor of neurosurgery at the Royal Victoria Hospital, Belfast, Northern Ireland, United Kingdom. Professor Onur Yaman, he is professor of neurosurgery, Memorial Hospitals Group, Istanbul, Turkey. Professor Toshihiro Takamai, he is professor of neurosurgery, Osaka Medical and Pharmaceutical University, Osaka, Japan. We will have case presentation by Dr. Mirza Poshki. He is affiliated to the Department of Neurosurgery, Philipps University of Marburg, Germany. And Professor Abdel Hamid Haidara, he is chairman of the Department of Neurosurgery, Bouquet Teaching Hospital, Ivory Coast. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time, sharing your knowledge and experience with young neurosurgeons, especially at this difficult time of COVID-19 pandemic, is well appreciated. The moderators of this symposium will be Professor Mehmet Zlili and Professor Onur Yaman. Professor Mehmet Zlili is chief at the Department of Neurosurgery, Edge University, Izmir, Turkey, past chairman of the Spine Committee of the World Federation of Neurosurgical Societies and honorary president of the Middle East Spine Society. I would like to thank Mehmet for supporting the organization of this event and for making such outstanding program. We have a very interesting topics today, as you can see over the screen, and we have open discussion at the end of the session, and then we will have case discussion as well. I'm glad to tell you that until yesterday, we had 657 participants over Zoom, and that's considered to be a very good contribution, and they are contributing from all the continents. We're also doing live stream over the Facebook page of CANS. As you can see, this is the address seen over the screen, YouTube channel of the Egyptian Society and Neurosurgical TV. I would like to thank John Bennett. Actually, he's doing a great job in promoting our series of webinars. All attendees, we are glad to get all your questions and comments, and it will be monitored through the chat panel or the Q&A. This is the type of certificates we are offering. Remind you that this event is recognized by the World Federation of Neurosurgical Societies, and these certificates are approved by the World Federation of Neurosurgical Societies as well. Concerning certificates, in all our previous webinars, participants were printing their certificates electronically. However, some participants encountered some technical problems. My IT team, they are now using a new method by which certificates will be sent to your emails automatically, usually sent within 1 week after the webinar is finished. However, certificates will be sent to only participants who participated for the specified amount of time as specified by the organizing committee, because actually we noticed that some participants just participated for 5 minutes and they were asking for certificates. And so if the webinar is only one specialty or one session like the webinar of today, for participants who would like to get their certificates, please participate for all the webinar from the beginning to the end. And I would like also to remind you that the names will be written over the certificates according to the name in the account of your email. And so please register from your personal email. If you register from another email, the name will be incorrect. We started to send certificates automatically since webinar number 53. As examples, you see the number of participants and the number of certificates sent according to the time specified. In the last webinar, which was a collaboration with University of Miami last Friday, 271 participants, only 83 certificates were sent to people who participated for all the time of the webinar. That's very important. I'd like to announce that the Pan Arab Journal of Neurosurgery, which had been relaunched after a silent period of 10 years. I'm honored to be the editor-in-chief of this journal. Please submit your articles. Publication is free. It's an open access journal, and the address is seen over the screen. As Treasurer of the World Federation of Neurosurgical Societies, I'd like to announce about the World Congress of Neurosurgery, which takes place from March 13 to 18, 2022 in Bogota, Colombia. I encourage everyone to participate in this important event. And we are going to see all of you in Bogota next March. Another important announcement, the Third Men's Congress will be organized in Egypt from 27 to 30 October 2022. I'm glad to be the president of this Congress, and I'm glad to work with Alberto Deli Talla. He is president of the Mediterranean Association of Neurological Surgeons. All of you are invited. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Let me announce about webinar 57. We will have vacation for 4 weeks because of the Christmas and the New Year. And we will restore back our activities by webinar 57 on Friday, 14th January at our usual time from 2 to 5 p.m. Egypt time. That's going to be a WFNS educational symposium with Professor Luis Borba, the chairman of the Educational Committee of the World Federation of Neurosurgical Societies, and it will be about hydrocephalus. May I wish all of you Merry Christmas and Happy New Year. Thank you very much. Now I give the talk to Professor Salman Sharif to say his welcome note, and then Professor Mahmoud Khorashi, President of CANS, to say his welcome note as well. Thank you very much.
Thank you, Nasser. I think you're doing an amazing job. I'm so happy that somebody from that part of the world is working so hard and making everybody work and study and keep the young guys busy. I think it's really a great opportunity for all the committees to get involved in people from this part of the world. And I'm delighted that we are contributing to your webinar series. I'm thankful to all 15 members of our WFNS Spine Committee, and also to the 35 members who worked with us before as well, because they've been involved in various activities with us. And I'm grateful for them to be a part of the Spine Committee despite not being in the committee itself. So they're working from outside, and we are so happy for that. And I think Professor Zalili, as always, have been forefront. He actually organized the whole thing. I just watched it from the back, and I'm grateful. It's wonderful to be a party with Moody as well, who has been a dear friend for a long time, and CANS. And we have worked with CANS for a long time. It's great to be affiliated again. Again, Egyptian Society has been close to us, and we have worked closely with them over the past, and hope that we'll continue to do so. And I'm grateful again to Nasser, who's a dear friend and a brother to me. And all along, he's been excellent in helping us with various activities throughout. And he was the one who actually got all the Egyptians involved in our webinars when we were doing them, started them at the time of initiation of COVID. So I thank everybody, and hopefully we all are going to have good fun. I request Moody, you can carry on from here.
Thank you very much. First of all, on behalf of the membership of CANS, I really want to say a big thank you to all those who are contributing today. A big thank you to Nasser, who's been our driving force in CANS for all the webinars. And welcome home to Salman. Salman has always been very supportive. Africa is his second home. If we have a teaching course in Mombasa, Salman is there. If we have a teaching course in endoscopy in Nairobi, Salman is there. And so is Mehmet. He's visited us, of course, from North Africa, South Africa, and West Africa with Professor Haidara and Ian Flock. Africa welcomes you all and thanks you very much for contributing to the knowledge and contributing to the training of our young neurosurgeons and residents all across this wide continent of 1.2+ billion people. So very, very warm welcome to you all. Thank you.
Thank you, Mahmoud. Now we give the mic to Professor Mehmet Zalili and Honor Yamad, who are the moderators of this session. Please go ahead.
Thank you, Dr. Nasser. Dear friends, it's my great pleasure to moderate this session with my dear friend Onur Yaman. I thank all the contributors, especially to the speakers, for making that program possible. In fact, one of our friends, Juti Partiban, could not join us. He unfortunately has lost his wife yesterday, and then his talk will be given by Sandeep from India. I want to invite the first speaker, Dr. Salman Sherif, to talk on the acute management of spinal cord injury. Dear Salman.
Thank you, Mehmet. That's really my pleasure to be part of this amazing series of webinars that we have. I'm here on behalf of the WFNS Spine Committee and also CANS and also Egyptian Neurosurgical Society. So I'm going to be briefly taking you through a small tour of about the management of acute management of spinal cord injury. This is important that we know what's the pathophysiology. So primary injury is when from an initial traumatic force applied to the spine. Could it be compression because of bone, disc, or ligament extruding into the spinal canal? That can cause the primary injury. Secondary injury is a process by which follows primary injury. It includes microcirculation disruption, loss of autoregulation, edema, and ischemia. So what we are there to do, whatever has happened, then we are there to prevent the secondary injury, and that is the most important thing. So initial management is evaluation, resuscitation, and mobilization, and you extricate the patient and transportation. I'm not going to go into detail of that, but the patient should be transported in a cervical hard collar and side head supports on hard board with straps. Why are the straps important? Because when we are moving in an ambulance, if your lower part is separate from the upper part, then you can seriously have problems of movement and actually cause more injury than benefit. The spine board should be removed as soon as possible once the patient is on a firm trolley. Prolonged use of spine boards can be rapidly lead to pressure injuries, and we don't want that. Full immobilization should be maintained all along. Hospital management also includes the management of neurogenic shock, spinal shock, autonomic dysreflexia, pharmacological therapy. And we will touch a bit of these over time when we go through the presentation. Log roll, additional standard maneuver to allow examination of back and transfer on and off the backboards. And this is the way to do it. So somebody is holding the neck up and apply a little bit of traction. And you need at least 4 hands to turn the patient at one time on the command of the person on the top. So you need 3 to 4 people, and then log roll, and you make sure that it rolls chest, pelvis, and limbs together. What is a Canadian C-spine rule? The 3 main questions. Is it a high risk factor, age more than 65, dangerous mechanism, paresthesias and extremities? If you have any one of those, you need to be thinking about investigating this patient in detail. You evaluate the patient, you look at abrasions, laceration, and deformities. For example, if you've got abrasion on the forehead along with neck pain, you can think about upper cervical spine injuries, because if somebody's got a flexion injury, that can give rise to that. Palpation for localization of pain is important, and this is for the whole of spine. Neurological examination, cranial nerves, motor and sensory function, reflexes, rectal tone, bulbocavernous reflex, incontinence, and then primary treatment focus on the ABC of resuscitation. Imaging studies, where you don't have a CT scan, you could do a plain cervical span X-ray, but as soon as CT is available, you need to get that. MRI is helpful as well, and we'll go through where we should do MRI, where we should not. Plain X-rays, if you don't have a CT, then you should at least have a plain X-ray, and you should be able to see all the way from base of the occiput all the way down to C71. You should not only see 3, 4, or 5 vertebrae, but in fact, all of them all the way down to the junction. If you're missing it, you need some other view for that as well. When we're looking at the AP, then obviously spinous process of the upper cervical through the first thoracic vertebrae should be clearly seen. And when you've got odontoid open mouth view, then you need to be looking at the overhanging of lateral mass, fractures, etc., various things that come into play. Missed injury with X-rays could be up to 1/3. This could be devastating, long-term serious consequences. So therefore, must be presumed until it is excluded. So the important thing is to get a CT scan, and the CT scan has to be obviously at least a high quality sagittal reconstruction, and you're able to see fine details about what has happened and what has not happened. And then according to the fracture types and the various other things, you can decide this patient needs further treatment or not. What about MRI? Yes, so we're going to talk briefly about MRI later on as well. It further defines the level and nature of injury. So, you can clearly see CT should have picked it up, but sometimes you could have a big disc prolapse, a bone piece sticking inside and causing serious problems. You identify the pattern and anatomical level of cord injury, and that is for prognosis, and Sandeep will be talking on that. Identify soft tissue injury, which is in front. So if for example, you don't see any fracture, but you see a little bit of blood in the front, then you know that something has happened at that level. You identify hemorrhage, edema, cord swelling, compression, canal compromise, and the longer retrocaudal lesion, the poor the prognosis is. What about if you see an unconscious or uptended patient? So ideally, you should get a CT scan. CT scan has a 98% chance of no significant spinal injury, particularly unstable fractures or subluxation. MRI scan does not give you 100% clearance, but if you've got a plain X-ray, CT are normal, then there is only a very low chance of a potential instability in the spinal column. We know this. There are some patients who would require traction, and those would be a displaced Jefferson fracture, Hangman fracture, type 2 and type 3 odontoid pec fractures, displaced subaxial fractures, subaxial subluxation and dislocation. The important thing to remember is in the Hangman type 2A, fracture traction may displace the fracture and adds dramatically to the risk of spinal cord injury and subsequent death. So this is contraindication. Also, occipitocervical fusion, you need to be very, very careful. Neurogenic shock and mean arterial pressure. Well, we know that there is decreased systemic vascular resistance with neurogenic shock. 25% of cervical spinal cord injury experience a component of neurogenic shock. So we need a maintenance of MAP of 85 or greater for first 7 days after injury because it's demonstrated favorable outcome. Dopamine, norepinephrine, epinephrine are common first-line agents for the treatment of neurogenic shock. Sorry, the mammoth is being kissed by Greg Frost, our friend from Wisconsin. This is one of our Karachi spine courses. Sorry, mammoth. Vaccaro came up with this classification, which is subaxial injury classification, in which you look at morphology. And morphology is when you've got no compression, compression, burst fracture, distraction, and then rotation and translation. And then you've got disco-ligamentous complex. Is it intact? Is it indeterminate? Or is it disrupted? The neurological status as well. And then according to that, we give scores. And if there is continuous compression in setting of neurological deficit with neuro modifier, then we add another 1 point to it. And depending on the number of points, you decide this patient needs surgery or not. So there is class 1 evidence that this cervical injury classification by Vaccaro et al. Is reliable overall, internal consistency indicated by worsening of score, reflecting the worse outcome. Well, spinal cord injury with the subaxial classification, does it really work? So if this is a database, again, by Vaccaro and Yoakum, and there's high agreement rate in SLIC score between different examiners and different surgeons, and the 90% is agreement between them. There is excellent intra-observer and inter-observer agreement among the surgeons of the SLICs. This demonstrated SLICs could be safe and effective in guiding the treatment. And then we have AO classification, which is actually quite detailed. The benefit of AO is obviously then again, it is able to predict which patients you should operate and what should be the mechanism. Previously, it used to be very cumbersome and a lot of problems, but now it's getting simpler. So we have got A in which we're looking at what type of fracture it is. So it's a wedge compression, split, incomplete, burst, and complete. And then you have got B is a type of tension bend injury, then in which you've got a posterior tension bend, anterior tension bend, or bilateral injury. Whereas then you come to C, and then you've got which is dislocation, complete dislocation. You've got facet dislocation. F1 is non-displaced facet fracture. F2 is facet fracture potential for instability, and floating lateral mass is F3, and pathological subluxation or purge facet is F4. And then you have got this algorithm that you follow. You have neurology is again given here in detail, in which N0 is neurologically intact, and then go on to severity of the injury, and the complete injury is N4. If somebody can't be examined, that's also included in this. And then there are modifiers which help us regarding what kind of surgery we can do and what kind of problems we can give to that patient. So the guidelines regarding radiology in asymptomatic patient, in the awake asymptomatic patient who is without neck pain or tenderness, or who have normal neurology, who is without an injury distracting from accurate evaluation, so you can evaluate that patient well, who's able to complete a functional range of movements examination, radiology is not recommended. You discontinue cervical immobilization in that patient. In the awake symptomatic patient, high quality CT imaging of C-spine is recommended. If the CT imaging is available, routine, if the high quality CT is available, routine 3-view cervical spine radiographs are not recommended. If high quality CT is not available, for buying time, you can do a 3-view C-spine series, and this should be supplemented with CT whenever it's available. Methylprednisolone, well, there's been a lot of talk about it. Treatment options for acute traumatic non-penetrating spinal cord injury. Methylpred was supposed to be given within 8 hours of injury, and they showed some benefit at that time. However, in third series, methylpred failed to demonstrate any effect in comparison to placebo. Additionally, due to increased risk of infection, its use is no longer recommended. So this paper in Journal of Spine Disorders from 2000 said that the reporting of results of NASCA studies 2 and 3 have been incomplete, leaving clinicians in spinal cord injury community to use or avoid using methylpred in acute spinal cord injury on the basis of faith, rather than publicly developed scientific consensus. So the guidelines are that administration of methylprednisolone for treatment of acute spinal cord injury is not recommended. It is not approved by FDA. There is no class 1 or 2 medical evidence to support this. There is class 1, 2, and 3 evidence that high-dose steroids are associated with harmful side effects, including death. So you need to be careful, especially in patients who are at high risk with other problems. So what about timing of surgery? When should we operate? There is this famous trial, Staskus trial, in which Michael Feeling looked at these patients, that patients who were operated within 24 hours and after 24 hours. At 6 months post-injury, early surgical decompression was associated with 2.8-fold increased odds of 2-grade ASIA impairment scale improvement, with no difference in acute complication. So that's what our goal should be, that we need to be trying to do these cases as soon as possible. We looked at our patients as well, and in the same kind of results that we got at 6 months follow-up, that 23% in the early group and 8% in the late group showed more than 2 ASIA grade improvement in ASIA score. There's evidence that surgical decompression and stabilization within 6 hours of a partial spinal cord injury will lead to 70% of patients improving by 1 or more ASIA grades. If surgery is delayed beyond 6 hours, there is only a 12% chance of such improvement. So there is a clear difference between, if you can operate these patients within 6 hours, if they're right to your center, then you should do it. Facet dislocation and management. Well, if it's mild unilateral facet dislocation, it is more often stable. Conservative treatment with close-up follow-up can be done if somebody is not fit for surgery, if somebody is neurologically intact, and external orthosis is inadequate for jumped dislocation facets. Bilateral facet dislocation, unstable and should be stabilized surgically. I'm not going to go into detail of how we should reduce this, but if it's an awake patient, it can be performed with monitoring. It's not recommended to obtain a pre-reduction MRI if it's an awake patient who knows what you're doing, who's intact. And you're able to reduce in majority of these cases. The incidence of extruded disc is really small, and the chance of neurological injury is really negligible. So over a series of about 600 cases, they found that the risk was really, really low in patients who we do not do MRI, move patient directly. Where we have the MRI available, we should do this if it can be done as soon as possible. MRI is useful, but not accurate in predicting. It's a controversial use. So this retropulsion through retropulse annulus despite normal pre-traction MRI. Disadvantage of MRI, obviously patient is transported to MRI and you're sometimes not able to monitor, and then delay in reduction could be a problem. Open reduction could be anterior and posterior. Dangerous in the presence of disc herniation, requires 3 vertebral fixation for 1 motion segment and stability, necessary to excise the facet, also requires 3-level fixation. Anterior approach, single segment orthopesis required, low infection rate, higher radiographically union rates, better lordotic alignment, more frequent voice changes and dysphagia. So patients who are above 75 or 80, they have a higher chance of having dysphagia, so you need to be careful, especially operating in the mid or upper cervical spine. Reduction intraoperatively when they're doing it open could be done via interbody spreader, by turning the spreader widely and at the same time turning the patient on one side. Bilateral facet dislocation, the spreader is obviously placed in the mid-vertebral body instead of on one side where there is unilateral. And then torque is applied on the long axis of the spine as shown here. Vertebral body fracture risk is there if you don't apply it well, or if you apply it too superficial and not deep enough. Posterior techniques and anterior techniques both are possible. So what you can do is you can put in your distractors, and you can apply it at an angle. Then you can turn it one way or the other, and you can reduce it. Once you're reducing it, you're able to distract it. So if you're coming at an angle and then you distract it, then you should be able to open it and clear it out. On the other hand, if it's unilateral, then the lateral placement of post allows torque applied. So what you do is you take it on one side or the other, and you can reduce the spine in that way in unilateral facet problems. As I said to you, MRI plays a crucial role in evaluating and detecting spinal trauma, but at the same time also give you some prognosis element as well. Subtle bone marrow, soft tissue, spinal cord abnormalities, which may be not apparent, can be seen. Early detection often leads to prompt and accurate diagnosis and management. Talbot et al. Came up with this basic score, which I think Sandeep will go into detail, so I'm not going to go into this and how it affects how and what we should do. I won't touch that. What about diffusion tensor imaging? Yes, we use diffusion tensor imaging in some settings, but the studies so far, we have had only 39 studies, only a couple of studies with only a year-long follow-up. How does it work? Conventional imaging, DTA performed in 25 of these patients with blunt spinal cord injury and 11 volunteers. And the parameters reflect the severity of spinal cord injury and correlates with ASIA motor scores in patients with non-hemorrhagic cord injury. What about functional MRI? Just like brain, we are doing this in spine as well, and we are doing this more and more. It's a non-invasive modality which relies on changes in the blood flow and oxygen level. So what we do is we use this bold contrast, which is signal changes related to both the blood oxygen level dependent contrast and signal enhancement from extracellular water proton caused by increase in water content in that area. As such, spinal functional MRI is able to map out areas of spinal function related to motor and sensory function. And it has shown that we are able to predict outcome according to the changes on the functional MRI. The WFNS Spine Committee went through lots of effort to come up with recommendation for spinal cord injury. We have had 5 consensus on various topics, including thoracolumbar fracture, osteoporosis, spinal cord injury, and spinal trauma. So I'm just going to go through the recommendations of the subaxial cervical spinal cord injury. SLIX system is safe and effective in guiding treatment of a subaxial spinal injury. There is good agreement rate, more than 90% in the SLIX score, morphology, neurology, and discal ligamentous complex, and the treatment chosen. In order to be precise for classification of subaxial fracture, we suggest use of MRI, although having said that, you can also use CT scan, which is a high quality scan. Modified AO classification is equally effective, although it's still a little complicated for some people to remember. There is no evidence that closed reduction of cervical lock facets have more benefits to open reduction. It should be done as soon as possible. If closed reduction is attempted, awake patients with incomplete injuries are better candidates. If a reduction in patients with decreased consciousness is attempted, pre-reduction MRI and open reduction should be preferred. If a closed reduction attempt fails, immediate anterior decompression and surgical reduction are better options. Best time for closed reduction is not well known, although most papers suggest it is as soon as possible. All patients after closed reductions should be operated for stabilization and fusion. We know as soon as we apply traction, the canal opens up by 30%, so you have 30% more space for the canal to breathe. And obviously that will give rise to better outcome in these patients. In the management of locked facet, if a posterior approach is considered, preoperative MRI is recommended, and you know that is to see if there is no anterior compression. Traction helps in immobilization in the unstable segment and then may help for reduction. In majority of acute locked facets, which is like less than 3 days, anterior surgical techniques are sufficient. In chronic locked facet, more than 2 weeks, lower cervical locked facets with no insignificant disc prolapse, and in condition where anterior approach is not feasible, a posterior approach is indicated. So I thank you for listening. This is actually the famous climbing area in K2, and this is the area where more than 80 hikers have given their life, and it's supposed to be a death trap. Going on to K2, which is the second tallest peak in the world in Pakistan. So I thank you all and thank you for listening. Thank you, Mehmet.
Thank you, Salman. In fact, all the participants can look at the website of WFNS Spine Committee to see the recommendations. You can also promote that. Actually, it is WFNS spine.org. Yes, I give the moderation to Onur.
Hello to everyone. Salman, thank you so much for this excellent talk. First of all, I'd like to thank Salman and also Kanduri for inviting us. The next talk will be Sandeep, but Sandeep is in the surgery now. I think he will be back when he finishes the surgery. If Jan Locke is ready, we can listen to Jan.
Yes, thank you very much.
Yeah.
Let me.
Jan, the topic of Jan is craniovertebral junction injury. Jan, please go on.
There we go. I'm assuming my screen should be up there and everybody can hear me. Is that it's all good? Fantastic. All right. So to all the participants here, thank you for joining, and it's a great honor to be here. You'll find that dealing with the spine as a young surgeon or a resident, that you come across, and Prof. Salman mentioned that there are so many classification systems. There are so many ways that people have tried to look at things and try to put things for you into a bracket and into a compartment to try and make it easier. Because at the end of the day, we've got to manage a patient. We have to make diagnoses and work through the systems, but we have to manage the patient. We try to make it easier on ourselves, but the reality of what we face at the end of the day is that there's always outliers. And your brain starts to put things in a bracket, and you try to accommodate the outliers, and it all becomes just so very confusing. But today we've got smartphones, and we've got a lot of things that we didn't have in the past. It's at your fingertips. So you can really look at these things very quickly. So I'm going to try and use to set your minds a bit free from those entities and try and make you think a little bit differently about it, and to see how you can try and help yourself in terms of a core decision, and then apply classification systems and see how you go about it. So I'm going to do this at the end of some examples and how we did things before. Okay, so just quickly, we know this is at least in our country, there are thousands of spinal cord injuries every year. It is a male-driven sport. It's testosterone that gets us into trouble, and it makes us do stupid things. And you can see the MVAs, falls, diving accidents, trauma, interpersonal violence. But we have two very distinct groups of spinal cord injuries. One of them is the younger group, the very high, fast-paced, action-driven thing. And then there's the older group, the older patients who get vasovagal, stenotic cervical spinal canal, minor injuries, and get the type of central cord syndrome. So there are two different ways that the cord can get injured by mechanism. But overall, the mortality is 17% with initial admission. So people do not leave the hospital, 17% of them after spinal cord injury. And all our efforts are aimed at trying to reduce that number and trying to give people not only more functionality, but also quality of life. So just a brief history into the past about the cervical spine. In 1979, 1/3 of cervical spine injuries were initially missed, with a delay in diagnosis up to a year. Then we started getting better, and our diagnostic abilities became better, and we designed this CT. And even with CT, 54% of subluxation and dislocations or only 54% were correctly identified. So what happened was the advent of systematic approaches to the spine, such as the ATLS, the Canadian rule, Nexus criteria, and you guys have access to all of these things. But all it does, it takes a physician, whether it's an EMS, a frontline worker, or a primary care center, or a specialist, a methodical way of looking at things and going through a system and trying to identify things that are outside of what we understand to be normal. We also have to appreciate the fact that there's evolution in our diagnostic ability. So we relied firstly heavily on clinical, then X-rays, then we now have CT more readily available. But myself being in Africa and in a public service space, we know that we don't have easy access to all the most advanced imaging. So we have to be able to rely on things that have been validated over many decades in the past. So I'm just going to briefly run through this because I don't want to take away from the next speaker's talk. But we know about the cervical spine, and our previous talk alluded to the fact that firstly we have to look at the quality of the X-ray. So if you look at an X-ray, you cannot take away from the quality. If it's not appropriate, it's not going to be diagnostic. So remember, there's a heavy head on a mobile neck on a rigid thorax, and that axis will create failure most likely at the base of the cervical spine. C6-7, C7-T1. So if you don't see that, if there's energy, you cannot clear an X-ray. we know that we've got certain lines, and I'm really just going to briefly run through this, but the ADA, the Atlanto-Dense Index or interval, it's a small space that's meant to give us an indication whether the transverse ligament is actually intact, holding the dens in position. We've got the soft tissue line. There are a lot of diagnostic criteria here. We know that we look at soft tissue to see if there's any sort of potential injury that's hidden. And we know that it's got to be a very little bit of soft tissue swelling around about to C5 and a little bit more. So some books say 7 millimeters onto 14 millimeters. Some books say 5 and 15, or some say half a vertebral body and a full body. But the shape that you see on the picture now is what you're looking for. You need to see that sort of indentation that goes across. The anterior body line, we need to make sure everything is aligned. And considering the cervical, craniocervical junction, you have to be sure that the C1 is included in what you're looking at. Posterior body line, again, running up the back of the bodies, and the spinolaminar line. So this is a line that I find very reliable for any craniocervical junction pathology, and we're going to be looking at that more clearly. But remember that the posterior arch of C1 has to be included in your line. Then there's a sort of a little bit of a lesser rule, not as hard, about the converging spinous processes. So we like to think that they converge onto an imaginary spot, but keep in mind that there is a lot of variance in the cervical spine. There's Klippel-Feil anomalies that might not make this as true as you would think. However, your eye might catch something that stands out. So it's also a nice soft line. So the things that we want to look at is potential instability in the CCJ. You know that if there's a neurological fallout, we have got it's very clear in the craniocervical junction. People often stop breathing, can have cardiac anomalies, or be a quadriplegic or paretic, but it's potential instability that you do not want to miss. Now, the C012 area is extremely forgiving because the canal or the spinal cord only occupies about 30% of the space available to it at C1. So therefore, neurologically, it is well protected. However, it's a very strong ligamentous complex is keeping all of that intact. And therefore, if we miss something there, there's potential disaster in the future. So I'm going to show you several cases to illustrate some pathologies and classification systems and how we apply them. But what I want you to think about is that as a neurosurgeon or a spine surgeon, you are going to operate for 3 reasons only. And remember this, you operate for instability, for neurology, or to decompress neurology, and for deformity. Now, deformity is a realm on its own. So potential deformity is something we have to look at. And again, things such as scoliosis, often you decide if you want to do it, or your orthopedic colleagues, but instability and neurology is what I want you to keep your minds in. And if we need to operate at the end of the day, is the information available to you guiding you towards that? Now, of course, neurology is a clinical diagnosis, and we know that we establish a baseline in terms of something like spinal cord injury and look at how our baseline fluctuates, but instability is what we want to see. So let's start. There's a 13-year-old girl. She fell out of a tree. She comes into our unit. Her neck is immobilized, and she complains of intense neck pain, neurologically intact. And this is her x-ray. So normally, if I have a big group in front of me, I'd like to ask people to point them out, but I will spare you today. So I'm going to see, looking at this lateral C-spine, and let's assume we can see the C71 interface on some other images. But what strikes your eye is significant soft tissue swelling in the front. We see there's some sort of anomalous arch of C1 at the back, and this is quite strange. Yeah, we don't often see through the C0, C1 joint space. It's something that when you look at enough lateral C-spines, you would know that that's not something we normally see. Also remember, when you look at an X-ray, X-ray is often focused towards the middle of the cervical spine, and it's a beam that spreads out. So you normally have your middle image that's perfectly lined up, and the rest of them is actually diverged up. So we don't generally see that. So by seeing that space, something's got to click in your mind and say, but hang on, that's not right. So this is a CT sagittal reconstruction of left and right, and you can see that the occipital condyle has moved forward out of the lateral mass of C1. So this is occipito-cervical dislocation. And this is a grossly unstable situation. So your mind's got to tell you, well, I cannot leave this in this way. The patient clearly has survived it because she's neurologically intact. So this has got to be united. So if you look at the classification system available to us, there's just an MRI image, but a classification system available to us. It's one by Vince Trinellis in the team, but it describes severe deceleration forces at the joint. All the ligaments are disrupted, or lots of them are disrupted through there. It's often fatal because patients who get a cord injury at that level will typically stop breathing. ATLS principles have decreased fatality rate, where people are actually resuscitated on the scene and actually makes it to hospital. Often there's a delayed diagnosis. And again, CT and MRI helps you a lot. It's divided into 3 types. It's either anterior, posterior, or upwards. Yeah, so if you think about it, I mean, the head can only go certain ways relative to the neck. But irrespective of this classification system, there's such significant ligamentous injury here that the management at the end of the day does not, there's really no doubt about it. So however you choose and whatever you have available to you, you can decide to do it. And again, there can be a lot of debate. So when you fix it, do you extend the level? Do you go far down? How do you actually achieve that? But again, that's outside the scope of trying to first understand the mechanisms and what you're trying to achieve. So this is what we did. This is a C0 to 2 with a lot of bony work and autograft and allograft packed in there. And quite interesting, you'll notice that the one rod is slightly longer, because once the head was fixed and you have the skull plate fixed and you've got a temporary rod in place, when you relocate that 0 into 1, that rod becomes a little bit longer, and I couldn't actually cut it off. It's actually quite a tiny little person. But anyway, she's doing very well. Everything is fixed. But the point of it was that our indication for surgery here was instability. Next case, 24-year-old male. He suffered a motor vehicle accident, and he had a target sign on his forehead. So a target sign is if the big bruises on the forehead, which means that the head moved forward. Often the patient was restrained by a safety belt. So therefore, there's a significant energy of a heavy head. And all you guys who are neurosurgeons would know, if you're in theater and you're applying your Mayfield clamp, for example, if you're holding that head, how heavy is a human head if the muscles do not support it? Now, that's a lot of energy going forward. The patient had a subtle myelopathy and he presented in a hard collar. So this is what we're seeing here. And it's quite simple. If you go systematically through it, you'll clearly pick up the problems, but you don't have to be very educated to see the severe angulation on C2 and C3, but things can be a bit more subtle than that. So what's the line that I like at the CCJ? It's the spinolaminar line. And you can clearly see the arch of C1 has gone way forward relative to 2, but also the angulation is sitting at C2 and C3. And if you look very closely and we try to identify the pathologies, we can see the facet joints, and you can clearly see that that part of C2 actually belongs on the back there. So this is a dislocation of C2 and C3, and there is a classification system that actually covers this, but one would imagine that this in its own right would then be unstable. So how do we manage this? Well, firstly, the spinal cord, there's a subtle myelopathy of the patient. Here you can just see it's a 3D reconstruction of it, and you can appreciate the dislocation. And there's the MRI scan, which explains why the patient has some neurological fallout. So within our minds, we say, well, there is a compromised spinal cord. The space the cord has is now less, and we have to fix that. So this happened, the patient presented in the early hours of the morning. So my very eager registrars then applied Cohen's calipers and started to reduce this. This was without consult. Now you can see at 21 kilograms of traction, they weren't achieving anything. And is anybody surprised by this? Well, no, because this here, if you can see there, this is a traumatic spondylolisthesis, and the pars of C2 is fractured. So all the energy of pulling on it was lost in that space. The space is opening up, but the joints will not be affected. So effectively, nothing would be happening. So you can see there's the arrow. And this was actually visible on the CT beforehand. One could have appreciated the fraction of the pars, and this is one that one actually cannot reduce and you have to deal with. So Levine and Edwards classified the type, the traumatic spondylolisthesis, or as the magazines will put it, the hangman's fractures. And we know that this is classified based on either the angulation of C2 and 3, as well as the translation of 2 and 3. And in fact, the management of all of these are actually conservative. We don't actually operate on them. The only one that's definitely needs surgical intervention is the type 3, because you cannot reduce the facet with a close reduction because the energy will get lost. A lot of this can be discussed, and there will be exceptions to the rule. And there are people who bridge this gap with a lag screw and try to pull it together. You've got patients potentially that cannot tolerate traction for a while or cannot tolerate immobilization, but those are the exceptions. If you look at the raw classification of it, we know that we can treat most of these conservatively. So this was a case example of one that definitely needed surgery, and it's based on the fact that we cannot reduce the neurological compression without actually operating. So our indication for surgery was neurology. Now, one could just pay attention to the type 2A is where it is angulated but not displaced. And it's the picture third on the top here, and the energy actually passed through the disc. And the argument is if you apply traction, you can in fact extend this and actually pull it off. Then you ask yourself, but how can this heal at the end of the day? How will this work? Because if you reduce it, that raw bone of the past fracture will actually unite beautifully, and the system will unite, and it'll become stable again. But you just need to get it in position. So these patients needs reduction, needs maintenance traction or immobilization, and ultimately conservative care will work for all of them, barring the type 3. And this is just how we fixed it. So we had to bridge the fracture, and there are many solutions to it. Again, horses for courses. You use what's available to you, and one also evolves as a surgeon. You get better at certain things, and but this is a very adequate solution, and at the end of the day, the patient was fine. Here's another case. This is a 20-year-old female. She had a history of chronic headaches and then suddenly collapsed. She arrived with a Glasgow coma score of 6 out of 15, but woke up very easily. She had a seemingly normal cervical spine X-ray, and this is a scout CT of her brain. This, in fact, was missed by our radiology colleagues because everybody was focusing on the brain, which ended up being normal. And in fact, if you look closely at the base there, you can see that there's an os odontoideum. So this is a non-assimilated or fully assimilated C2, and this inherently is an unstable situation. Now, os odontoideum is classified in many ways, or actually 2 ways. One is acquired and one is a congenital os by itself, but that little piece of bone is held to the arch of C1 by the transverse ligament. And this gap in between is fibrous, but it's not as strong as bone, and therefore it will allow mobility, and therefore it's an unstable construct. Now, what happened in this girl's case is she had a singular vertebral artery, so which means that every time she was moving forward, she was getting vertebral compression. And in fact, when she moved too far forward, the vertebra artery compressed and she actually lost consciousness. But then it reduces, and one cannot actually see the problem. This is the MRI scan on the right-hand side, and you can see that in the immobilized position, the spinal cord is fine, but there, just below the os, there is a gap, and the patient can move there, thus it is unstable. So she was fixed by a C1, C2 immobilization, and that solved the problem, but it was almost very easily missed. And this is something you will see because these patients will typically present to you in some form of extreme fashion. Another case, 26-year-old male. Again, all these cases seem to be males. This is the testosterone-driven part I was speaking about. Now, this patient is very interesting. He had a motor vehicle accident 4 weeks prior to presentation. He came in severely myelopathic. He described the limit sign of severe shock-like sensations throughout his body, and he had severe neck pain. And this was his X-ray. So what this is another example of a traumatic spondylolisthesis, except this now slowly moved forward. It was undiagnosed, or the patient did not seek help. And now it has left itself 4 weeks later with a lot of scar tissue and a severely compromised spinal cord in a very unstable situation. And now you ask yourself, well, how are we going to fix this? Because to try and get that back, how do you go about it? And again, it's a bizarre looking images. This is the patient. I applied traction. I put the patient in traction, which immediately helped to relieve some of the neurological fallout. But now imagine the pars fractures off. If you acutely reduce it, it can reduce. But if all of this comes up, it can never get back to where it was. So therefore, you've got to think about what's the end goal of what I'm trying to achieve. So this is unstable. The patient's slowly progressing. So we need to try and achieve stability. So how are we going to do that? Well, this is just an example. We had to fix it, put a block in the front, put a plate over it, turn the patient around, and stabilize it from the back. And this is ugly. Looks ugly. And you put this X-ray up and people are going to wonder what's going on here. But we have taken the instability, we've managed to stabilize it, and we've managed to free up the cervical spine. So if you're going to find a textbook with a classification system of severely advanced traumatic spondylolisthesis 4 weeks down the line, there is actually not a lot of brackets for it. And your brain has got to tell yourself, well, what do I need to achieve? Stability and reduce the neurology. And the biggest threat actually is the plate in the front here. That's a swallowing, for the swallowing. And for now, the patient's still doing great, which is about 3 years down the line. So 24-year-old male again, fell down a flight of stairs. It seems to be a bad age in my hospital, 24. Patient was neurologically intact, had severe neck pain. So this is the X-ray. If we look at it closely, you can actually see there's a fracture in the arch of C1. Now, this is the open mouth view of the patient. So just a little bit of anatomy quickly. The C1 arch is a ring. It acts as a washer between the skull and C2. So this is a very intricate ability for us to rotate. But this washer, or this ring, is very susceptible to extreme flexion, extension, extreme lateral bending, and of course, axial compression. And it acts as an interface between C1 or the C1 and C2 interfaces by virtue of the transverse ligament. So the ligament is onto the lateral masses of C1, and it holds the dens in position, allowing us to rotate the head. But it also allows the dens, when we flex and extend, not to dig back into the spinal cord. So when do we know that that ligament has failed? How do we know that? Now, to look at a ligament, we cannot use an X-ray, or can we? If you have an MRI, that's easy. We can assess soft tissue. But over the years, we have realized that if you look at an X-ray with its 18% magnification rate, we can determine the stability of this situation by virtue of the extent of this washer fracturing out. And that's called the rule of Spence. So if we look at the open mouth of the X-ray, we can see this is the lateral mass of C1, and the overhang is measured and calculated, measured in millimeters. And if it is 7 millimeters or more, we know that the likelihood of the transverse ligament having failed is close to 100%, or it's significant. And therefore, we consider that situation to be unstable. Falling back again to what I try to tell you, neurology and instability is really, really important to emphasize. Now, this is an axial view, and we can see that the transverse ligament is holding this dens in position. So if the lateral mass is too far out, that ligament cannot do what it's meant to do. There's another example of it. And therefore, we're using a bony image to make a soft tissue deduction, ligamentous deduction. This has been validated over hundreds of thousands of X-rays. Now, we know that these arch of C1 are classified. It's according to Jefferson, and it's either a single arch or both arches, the type 3 or the so-called Jefferson's fracture. And then there's a lateral mass fracture. But all of them are stable, barring any one of them that has gone too far out, resulting in a failure of the transverse ligament, making the dens a danger to the patient themselves. Right, another case, 21-year-old male, motorbike accident, neurologically intact, came in with neck pain. Now, quickly about the dens itself. The dens also interacts quite with the transverse ligament, but also the apical ligament. And we know in the pediatric group or smaller group, the apical ligament, or coming off the tip of the dens, plays a much more important role as compared to when we age and when we actually skeletally mature. But this is based on, or this classification system is on the tip of the dens, or the base of the dens, or through the body of C2. Now, this is based on the lateral. There are other more coronally classified or classification systems of the dens, but I'm going to focus on this because effectively, when the dens is fractured, it leaves us with an unstable situation. Now, do we have to operate? Well, not necessarily, because if we treat the patient conservatively and the bone will unite, we know that you will regain stability without actually compromising mobility. Now, this patient, as you can see there, fractured below, just not the tip, but a little bit lower down, and he had a wonderful fracture configuration for a very simple solution, which is a den screw. But if we are going to try and treat the dens conservatively, if we keep it in position with traction,
you must come to conclusion.
I'll wrap it up. We have a lot of things to consider. So is the bone going to unite or not? And that's based on age, configuration, history, etc. And that in contrast to this case, which is a neglected patient who will not be able to manage conservative care at the end of the day, needs to be operated. So just quickly in summary, the craniocervical junction is a very forgiving area neurologically. but we have to pay close attention to any form of instability using classification systems we have. And we have to always remember, what is the purpose of us as neurosurgeons to operate? It's to decompress neurologically and to create stability and to avoid or correct deformity. So thank you very much for your time.
Jan, thank you so much for this excellent talk. Francesco was having problem to enter the meeting. Is Francesco here?
Hello, yes, sorry, but
Welcome, Francesco. Your topic is subaxial cervical spine injury. If you're ready, we can listen you. Francesco.
yes,
I think you have a connection problem.
okay.
Salman, is it same? Zilali, is it same? Is the voice clear?
Yeah, I think we can't hear him well. I think he's got connection problem. We can move on and come back to him maybe later.
I think Francesco tries to. So is Bajamal ready?
Yeah, Hafid is here.
Okay.
Francesco, if you can find the chance to connect again. So the next speech is classification and radiologic diagnosis for thoracolumbar spine fractures. If dear friend Bajamal is ready, Bajamal, please go on.
Yes, okay. Assalamualaikum warahmatullahi wabarakatuh. Dear friend, dear senior, dear participant, can I join my slide? Can you see my slide?
Yes, we can see it.
Okay. Yeah. It was a pleasure to have a virtual meeting with all you seniors and participants. First of all, I would like to thank for the opportunity to Professor Salman as chairman of the World Federation of Surgical Spine Committee, and also the past president, Professor Mehmet Zilali, and also to Professor Nasser Al-Gandar, who is very active and energetic. Thank you very much. I'm happy to see all of the friends. I will present about radiological diagnosis and classification system of thoracolumbar spine injury. So the thoracolumbar injury is the most fracture site according to more than half of a spine injury. And the myonucleus is very weak in the junction, and the canal also in that region is narrow, predisposed to spinal cord damage, resulting up to 40% of neurogenic deficit in trauma cases. In young patients, the fracture occurs due to the high energy of trauma. In older patients, usually encounter with osteoporosis. The most common type is burst fracture, nearly up to 40%, EO type A3, and followed by compression fracture, EO type 1. Now, it's after mechanism of injury and clinical condition information, and then you make an imaging result. This needs anatomical alignment, deformity, and stability information. And from this, you make a classification and see the classification, whether the patient needs conservative therapy or surgery for reduction, decompression, deformity correction, or stabilization. Let's see the imaging of the diagnostic. So imaging evaluation, X-ray and CT scan and MRI. The standard evaluation is X-ray. You can see the spinal alignment, percent of rotation, translation, assessment of kyphosis, vertebral height, interspinous distance. But 25% of burst fractures are misdiagnosed as compression fracture if radiograph alone are evaluated. So CT scan is the most important. I think, according to my experience, it's a routine procedure because it characterizes the fracture better and provide a degree of canal compromise also. And MRI is a good information for soft tissue injury, especially spinal cord root injury. You can see edema, hemorrhage, and evaluate the interspinous disc and PLC also. But the important thing, if you do MRI, then please do whole spine MRI, because in the literature there is identified that nearly up to 30% of risk of adulation. Now, imaging factor, it consists of displacement or dislocation, vertebral body height, spinal canal diameter, posterior ligament complex, and spinal alignment. This is 5 important things we have to evaluate during imaging of the thoracolumbar fracture, because this factor can determine the decision to do decompression, deformity correction, proper reduction, and stabilization with or without fusion. And this factor also very important for evaluation of the outcome of the surgery. Now, the first is displacement dislocated. There is translation injury which gives a rotational dislocation, and this is the most severe injury of the thoracolumbar region. The second is anterior vertebral body height is very important. You have to compare between the normal upper level and normal lower level, and sometimes you have to measure how the loss of the vertebral height, because if the anterior vertebral height loss more than 50%, it will risk of kyphosis in the future. And canal diameters is also important. You see, this is the normal and upper level, and lower level and normal. This is the fracture level. And you have to measure the ratio in the canal, and if the ratio is lower than 0.4, then this is highly associated to neurologic injury. This is very important, especially in partial neurology deficit or intact neurology. Now, the next is PLC. The assessment of PLC is very important because it can influence the severity of the fracture. If there is a PLC positive, it can change the treatment from the conservative to surgery. Now, you can see the interspinous distance between upper cervical spinosus, after the thoracal spinosus and lower part. The distance is, if more than 7 millimeter or enlargement in AP view, this is suspect of unstable and usually need surgery. If you're doubtful about PLC integrity, you have to look carefully, and maybe you need surgery for this case. Now, this is important thing, the alignment. This is cup angle is important. Now see, the target is reasonable correction, because the insufficient correction late will give progression kyphosis. Now, according to Schultz, the cup angle lower than 7 for reasonable correction outcome if you find after the surgery. But if more than 10.5, the cup angle immediately after the surgery, it means that maybe it's an unfavorable radiological outcome which is related to poor clinical outcome. This is more than 10.5 is suspected for unfavorable outcome. According to Vaccaro and Chu, that cup angle more than 20 grade is maybe there's correction loss and strong correlation with severe back pain. Let's now go into the classification of thoracolumbar fracture. Definition is the classification is to classifying something according to quality, characterize or observe similarity between the treatment doc physician. The goal of classification to get a common language in description the injury, in type and severity the injury, and guiding the management of the treatment. This help to give an accepted treatment algorithm to define also. Now, history and evaluation of the classification system. SETI given evolution of the history from 1929, the first classification of anatomy is doing by Boller, and 10 years later by Watson and Jones, the morphology, and he explained about the importance of PLC already. And in 10 years later, they call interspinous ligament as a major determinant, and 20 years later, Kelly and Wessel introduced two-column instability. Holsworth introduced the first time about the first burst fracture. And in 10 years later, Dennis introduced this important, very famous three-column law. This is about instability. And in the same year, McAfee predict instability. Also, the next 10 years, Ferguson and Allen give the pattern of failure. But in 1994, EO spine, according to Megel, give a type classification of type of injury. And 2004, this is thoracolumbar injury classification system. Give a point system and give the severity. And in 2012, the DO modified 3 types of injury. This is important, comprehensive, defined injury. This is 3 types, and we will discuss only 2 classification in short. Let's begin with thoracolumbar injury classification. This is developed by Spine Trauma in 2005. It consists of 3 parameters: morphology of injury, posterior ligament, neurologic involvement. As you can see, there is a point here. You see the burst fracture 2 point, translation 3 point, distraction 4 point. If there is intact PLC is 0 point. Neurology also, cauda equina, and incomplete cord is 3 point. So if the point is more than 5, it's considered for surgery, but if 4, it depends on the surgery experience. Now let's see the concern about this consensus. According to Azam, in rotational injury with 3 point, with intact PLC 0 point, and with intact neurology, does not require surgical because only 3 point, but actually this is more unstable and distraction injury. Because see, only 3 point, this is intact, this is, so the management plan is non-surgery. Only 3 point, non-surgery, but this is according to AO classification is unstable. Now, another concern is in L1 burst fracture injury with 2 point, with intact PLC 0 point, intact neurostatus 0 point, and according to this is only score 2 point and non-surgery, but this is there was, according to Nataraj and Joachim, there was 20% loss of height with kyphotic angulation more than 50%. Now we discuss about AO classification. The parameter of classification is for displacement, tension band, vertebral body fracture, and vertebral process. How to use the AO classification? According to my experience, it's very simple. You start with displacement is dislocation. You ask about this. If there is a dislocation, then it is included in type C. This is very most severe injury. You see this is the picture, rotational and dislocation. And if there is no displacement, then you go to the next question. Is there a tension band injury? If an anterior positive, then this is including hyperextension is B3. If there is posterior, you have to ask, this is osteoligament or only osseous disruption. Osseous disruption in B1, osteoligament is B2. This is if the PLC also positive injury PLC, then it is need a surgery. Now, the next, if there is no tension band, then you have to ask, is there a vertebral body fracture? If yes, and then you have to ask, is a posterior wall involvement? If there is no posterior wall, only anterior wall, then asking about, is there both end plate involvement? If no, then this include in wedge like this, E1. If there is both end plate, but in the midline, that is pinch or pincher. Now, if there is both implantment, then you have to ask, is there this, you see, the both in end plate, upper and lower end plate is in complete burst. If just only upper end plate like this is in incomplete burst A3. So this is an unstable case, A4 and A3. And next, if there is no vertebral body fracture, then you have to ask the vertebral fracture process. If yes, then this is A0, insignificant injury. If there is no vertebral process, there is no injury. So this is the track, all of the track you can see. This is the red color is unstable and needs surgery. This is not surgery. So, according to World Federation Neurosurgical Spine Committee recommendation, that the classification for thoracolumbar fracture, both current EO and TLESCS classifications are valid and can be used in clinical practice for traumatic thoracolumbar. But recent research indicate that considering its complexity, the current EO classification could be more useful in treating thoracolumbar fracture. And about radiological diagnosis thoracolumbar, World Federation Neurosurgical Committee recommendation is if a CT scan, MRI scan is not available, the anterior, posterior, and normal X-ray may be obtained. Although CT is still critical for trauma evaluation, it cannot accurately demonstrate the soft tissue injury. The memory should be considered. MRI is the most often used advanced imaging technique. It is preferred diagnosis for disc ligament disorder, spinal cord abnormal, other pathologic involvement. Now, let's see some case practical about classification. This CT scan can depict clearly the image that can occur of this injury. You can see the posterior and anterior wall injury. You see that the vertebral height is lost more than 50, and there is damage in the posterior interspinal damage. Then AO classification, you can see it is AO anterior posterior wall, complete burst, type C fracture dislocated, score 8. The treatment, laminectomy, decompression, element stabilization, long segment fusion. The next is, this is a case with anterior vertebral body height loss, not more than 50%, but canal ratio is lower than 0.4, PLC injury, dislocated, maximal kyphotic, paraplegia, AO class C, type class C, and score 8, treatment laminectomy, decompression, alignment stability, long segment fusion. The next is, this is important, this it's beautiful image in the MRI. You can see the injury of spinal cord, the PLC lesion, fractures of spinal process, and you can see the vertebral body injured. So the anterior vertebral loss more than 50%, the canal ratio, even the canal ratio is normal, PLC injury, kyphotic more than 50 grade, paraparesis, complete burst, score TLC is score 7. So this is very unstable, need anterior and posterior fusion. The next is this case. This is posterior wall involvement. You see this is anterior and posterior. So the anterior body loss not more than 25, canal ratio is still good. Slight kyphotic, no deficit, type A3, score 2, stabilization, short segment fusion. Now, this is important. Patient with fracture, posterior wall intact, lower end plate also intact, lower end plate intact, posterior intact, and the patient is fetal body height is small, slight kyphosis, no deficit neurology, only severe axial pain, type E2 stable. The score is 2. We do only kyphoplasty is enough to treat the pain. So the conclusion is CT scan imaging is very important because it can show better characterize the fracture. If an MRI be available, a whole spine MRI should be done because usually thoracolumbar fracture is accompanied by other lesion is about up to 30%. Obtaining as much information as possible about imaging factor is very important, not only to determine the type of surgery, but also to evaluate the outcome. The classification can help in providing recommendations for the treatment. It is important for the spine surgeon to understand the strength and limitation of different classification systems. Thank you very much and greeting from Indonesia.
Jamal, thank you so much. So I think Francesco is ready now. Francesco?
Yes, I'm ready. Thank you, and sorry for the problem and the technical problem before. I share the monitor, and I am ready to go to my talk. First of all, I want to thank you all the committee for to invite me to speak about the subaxial cervical spinal injury. Professor Salman Sharif have take a brief record about the topic, so I can go very quick in some part because his presentation was really outstanding about this. We know that injury of the subaxial spine, so located from C3 to C7, are among the most and potentially devastating injuries involving the axial skeleton, and account for almost 70% of the cervical spine injury. Mainly are due by car accidents, falls, or sport accidents, and are the consequence of various forces involving the subaxial spine, and this change in this biomechanical aspect of the trauma can lead to different stress to the mobile cervical spine and have compression, burst, distraction, or translation rotation injuries. Mainly due to the weight of the head, the cervical spine, the subaxial cervical spine are correlated with the flexor extension movement during the trauma. So mainly we can observe injuries of the facet joints with dislocation, and this act can change and can cause fracture of the vertebral body, of the pedicle, of the facet joint, but also of the osteoligament elements. So when we have to manage a patient with a cervical trauma, we have to think also of this part of the osteoligament element. Regarding the radiological assessment, obviously the X-ray represents the first exam that in every emergency department is available. We can have a direct visualization of the facet dislocation, of a vertebral listhesis, and the evidence of some vertebral fractures. Obviously, the CT scan provides us more information, as Professor Jamal showed in his part about the thoracolumbar fracture. Again, the role of the CT scan is very essential because we have more precise evidence of the vertebral bodies. We can study very well also the axial plane that are not available on the X-ray, and we can understand if the foramen of the vertebral artery is involved, if there is a potentially lesion of the vertebral artery. In this case, we can complete the exam eventually with the angio-CT scan that can show us some kind of lesion of the vertebral artery. Obviously, the MRI provides more information about the soft tissue. So we can again have the visualization of the listhesis of the vertebral fracture, but we have a direct visualization of the disc lesion, the presence of hematoma, the spinal cord compression, the definition of a spinal cord injury, and the detection of ligament status. Obviously, all these information are essential to define also with the new classification tools if there is an instability and the concept of instability. And here we can see the same case studied with a different type of exam, the different visualization and the different information. So often it's very important to manage and to compare all the information of each exam can provide us. As Salman said before, the Spinal Committee of the World Federation have performed in the last years, also with the head of Zileli, a great work about the recommendation, and the cervical spine was one of the latest paper done and was published in the beginning of 2020. In particular, for the subaxial cervical spine injuries, in this paper, the Spinal Committee have analyzed all the aspects from the classification to the management and the analysis of the vertebral artery injuries. In particular, regarding the classification, this is the review of the literature of the last 10 years from 2009 and 2020, were identified 22 articles about the subaxial cervical spine score system and 10 regarding the house spine. In particular, the SLIC is the new and the more used actually classification system to manage the subaxial cervical spine trauma. The difference between the other grading score that was completely abandoning the mechanism of injury, but addressed mainly the neurological status and the distal ligamentous integrity, in order to define a score that range from 0 to 8 that helps us to define the management. For value from 1 to 3 is suggested non-operative treatment. For more than 4 points is a clear surgical lesion, while the value of 4 remain in the gray zone, and the surgeon have the possibility to manage both with conservative and non-operative lesion. However, surgery remain indicated for the presence of a progressive neurological deficit or in the case of a significant spinal cord compromise. The algorithm provides also some information about what kind of approach for the surgical approach. Compression burst injuries are suggested to treat mainly with a single stage, while translational or rotational injuries can be treated posteriorly or more often with a combined approach by anterior and posterior approach. Regarding the literature, one of the most interesting studies regarding the role of this score is the study of 2015, where the colleagues analyzed in group 1 the experience of the management of the trauma between 2009 to 2010, where the treatment for the subaxial cervical spine was based on the surgeon experience, while from 2011 all the cervical trauma were managed using this score. And finally, the results of the study show that this system, this score system, helps to standardize in this hospital the management of this trauma. So it's safe and is effective for defining the management. Again, in these other studies, the results are pretty similar, and this score system is useful, and they suggest that it's the best classification system. I don't know if it's the best, but it's very useful to manage the subaxial cervical spine injury. The other classification system is those proposed by the house spine, that is very known by everyone. Salman show us the concept of this grading system, so I skip. It is mainly based on the type of fracture and the mechanism of injury, and helps surgeons to define, according to the mechanism of the trauma, to define the surgical treatment. Also, this is very reliable and can help also in the communication between the different centers. Finally, the recommendation about this topic of the classification, the spinal committee suggests that the subaxial injury classification is accepted and effective in dividing the treatment of subaxial spine injury, and that there is a good agreement between the SLIC score and the treatment option chosen. However, the role of MRI is stressed by the group, so when it's possible and feasible, an MRI is very useful to define also the classification. The second topic analyzed by this paper is the directive of the management of the subaxial cervical spine. Again, here is summarized the literature search performed for this reason, and the treatment range from conservative to the surgical one. Mainly, we move from the close reduction, immobilization, and surgery with the aim of the surgery, that is fixation and fusion. Regarding the close reduction, aim of the reduction is to realign the cervical spine, and mainly that can be performed directly with a Mayfield or with a traction, in order to have a reduction also of the compression. But it's suggested to perform the close reduction directly in the operating room if it's feasible, in order to provide also to a stabilization, also because of this kind of stabilization must be fixed. The role of a close reduction remain not clear, remain a little bit discussed, also because many authors suggest a direct open reduction, that we can you can read, but Salman have presented yet, and remain 2 points that are essential, that all the patients that are after close reduction must be operated for a stabilization and fusion, and for this reason probably performed directly in the operating room can be useful. The second one is the role of the MRI. If the patient is awake and we can manage and have a clear and precise neurological evaluation, and MRI is not available, we can skip this exam. But if the patient is not conscious, I think that MRI is an essential. Regarding the surgery, surgery is indicated for unstable lesion with progressive neurological deficit in order to provide instability. In particular, the principal aim of the surgery is the realignment of the spine, the compression of the neural elements, and to provide a mechanical stability. Obviously, this can be obtained by an anterior, posterior, or combined approach, and this is mainly depends of the kind of fracture and what kind of maneuver we need and we are able to perform. In the paper are proposed these algorithm of treatment, and we can see that mainly in treatment are by an anterior approach because provide a direct stabilization, but in some cases a full posterior approach can be indicated. Also for the reduction maneuver by an anterior and the posterior approach, Salman Sharif have shown more precisely the different type of maneuver that are direct or indirect. And I can show you a case. In this case, there is an anterior lesion of the disc with also posterior, as we can see in the MRI, lesion of the ligaments and of the muscles. And in this case, it's performed a full anterior approach with a cage and a plate system. By a posterior reduction, again, we can use different devices from screws, but also some pins that can help us to change the position. And some authors suggest fixation only by a posterior approach with a good realignment. However, in some cases, is indicated to perform a combined approach. Here are similar cases that the other proposed by only a posterior approach. This case was treated initially by a poor posterior approach, but the system failed, so was necessary to perform a second surgery with a posterior release and a partial realignment, an anterior approach to correct the disalignment and to provide the stability, and the final a posterior closure. Again, we can summarize the recommendation of the spinal committee, but it was presented by Salman. It's quite clear that for injuries with the SLIC score more than 4, early surgery is recommended. The role of early surgery, the definition of early surgery is another topic that is very discussed. Usually is accepted that surgery must be as early as possible. Some authors suggest less than 24 hours. It depends from the center. To obtain these results, the trauma must be referred to the fourth line trauma center. Finally, the last aspect is for the locket facet, that is a specific situation in which the inferior articular process over the superior articular process of the vertebra below and becomes locked in the position. The role and is mainly caused by hyperflexion with combination with some kind of flexion. Many authors suggest close reduction, but the attempt to obtain a good result with close reduction is time independent. In fact, if the maneuver is performed within the first days, the success rate is around 64%, while if it's the attempt after 3 days, is dropped down to the 20%. And here the algorithm for the treatment. Okay, is very important to perform as quick as possible. And this is the recommendation, but we have seen before, so we can go quick, and you can find also on the website as Zileli described very well. Finally, management of the vertebral artery injuries. It's quite difficult to define studies about this because are mainly case series or single short communication. We have to know that the incidence of vertebral artery is around 0.5 of all trauma patients. But when we study, we can see that a vertebral artery injury occurs in 17%. So we have to know about this, and if the CT scan show if there is an alteration of the vertebra close to the foramen, is indicated to perform an angio CT scan, and eventually, if with the angio CT scan we observe some changes of the vertebral artery, to perform directly an angiography and the treatment. And here the recommendation of the spinal committee. In conclusion, the World Federation have performed many guidelines. Some arguments were more easy to treat because there are a lot of evidence-based approach. While the role of this paper, of this recommendation, is very important for those arguments like the locket facet and the vertebral artery injuries that are less standardized. However, it's important that it's time to try to design randomized controlled trials in order to have better answer about the reason of the management of this kind of lesion. This is the previous webinars that we made some days ago. So just to say thank you to everybody.
Francesco, thank you so much for this nice presentation. So I'd like to thank also Nicola. It was its turn, but we changed our lectures. So thank you, Nicola.
I'll forgive you that.
Thank you so. Thank you, Nicola. So my topic is post-traumatic kyphosis. So post-traumatic kyphosis after thoracolumbar spine fractures. There is no reliable definition of post-traumatic kyphosis. So there are some angles that we can measure. One of them is Cope angle, the angle between the line parallel to the superior end plate above the vertebra that is fractured, and a line drawn parallel to the inferior end plate of the vertebra below the fractured level. Another angle is Gartner angle. This angle, you draw a line from the upper part of the superior end plate of the fractured level, and you draw a line at the inferior part of the fractured level. Another angle is vertebral compression angle. You draw lines from the upper superior end plate and inferior end plate. Another ratio or angle that you can measure is the anterior vertebral body compression rate. You measure the anterior vertebral height and also the posterior vertebral height. This is the ratio between the anterior and posterior. So the biomechanics of the thoracolumbar fractures that causes kyphosis is there is a loss of the height in the vertebral body. The disruption of the posterior tension may lead to the kyphosis. The compensatory mechanisms tries to achieve the sagittal balance. One of the important mechanisms in this traumatic kyphosis cases are lumbar hyperlordosis that I will show a few cases after it. So the existing of the kyphosis progresses the load on the anterior column. It causes a sagittal imbalance, and because of the kyphosis, the paraspinal muscles get stretched, and it causes inflammation and also pain. And also in the progression of the kyphosis, neurological damage may occur according to the stretching of the cardioequine fibers. There are two types of the deformity after post-traumatic cases. In the first type, there is a local kyphosis, but the sagittal balance is kept. In the second one, you have a kyphosis with sagittal imbalance. So the literature says that there is no association between the kyphosis and pain, and there is no definite angle that you have to decide according to the angle. You cannot decide the surgery. You have to decide according to the symptoms. So if you have an stable burst fracture, conservative and surgery, there is no difference. But if you have a unstable burst fractures, the surgery is better than conservative treatment. But the fixation construct remains debated. Another controversial in post-traumatic kyphosis cases is the time for surgery. The literature says that even if it's less than 2 years, you may have benefit after the surgery. So the duration of the surgery, if you have a less time than 2 years, it may help you to give a chance for the patient to operate them. So indications for surgery are increasing axial back pain, radiculopathy or increasing neurological deficit, pseudoarthrosis or malunion, and breakdown of the level that you have operated. It means adjacent segment disease that you have fixed that patient. So anterior surgery has an advantage to relatively have a direct approach, and you can put the devices into the anterior structure very easily. But posterior surgery has advantage because it has less bleeding, less surgery time, and you can do everything from posterior. There are lots of osteotomy techniques here. So posterior surgery is an alternative way to anterior surgery. So combined surgery is another option. So another thing that we have to discuss is the level of the fusion. The literature says that if you do short fixation, you may have loss in the correction in time, and you may have more pseudoarthrosis in the follow-up. So long fixation has advantage to correct the spine to kyphosis easily than short fixation, and also the pseudoarthrosis rates are less than short fixation. So this is the study from Ituerta. They have compared lots of short and intermediate screws. Intermediate screw is that screw that you put into the fractured level. This study shows us that even it's short or long, if you put an intermediate screw in the fractured level, you may have more chance to correct the kyphosis. Osteotomies are another technique that you can correct from the posterior approach. If you have a type 1, it means you have a focal kyphosis with sagittal balance. You may use Smith-Peterson or Ponti osteotomies to correct the spine. If you have a greater sagittal imbalance, or if you have a sharp angular fused kyphosis, the osteotomy that you have to do has to be a higher osteotomy. It means you have to apply a pedicle subtraction or VCR. So this is an algorithm that Bukowski and his friends has published. If you have a normal sagittal balance, and if you have a smooth kyphosis, Smith-Peterson osteotomy, Ponti osteotomies will help you. But if the patient has a global sagittal imbalance, and but if the kyphosis is smooth, again, Ponti and Smith-Peterson osteotomies will help you. But if the patient has a global sagittal imbalance, and if it's greater than 5 centimeters, and if it's sharp angular kyphosis, the osteotomy type that you have to use is pedicle subtraction and also VCR. So this is only 2 cases that I want to show you. This case was 25 years old. You see the patient has a focal kyphosis here. The patient's sagittal balance is fine because the patient has a hyperlordosis here. So we have operated the patient with Ponti osteotomies here, and we lengthened the fusion levels. You see the patient has a normal lordosis after the surgery. Another case, this case was 27 years old. The patient was fused with short instrumentation. I think in the follow-up, the patient get a focal kyphosis here. Again, the patient tries to keep the sagittal balance with hyperlordosis here. And you see the patient has a hypothoracic kyphosis here to try to make this sagittal balance in a normal position. Then we have operated that patient with BCR. You see the hyperlordosis is now changed to normal lumbar lordosis. So these are our keynotes and also WFNS recommendations. The most common reason of post-traumatic kyphosis is untreated, unstable burst fractures. For the treatment of post-traumatic kyphosis, there is no definite kyphosis angle to decide the surgery, but global sagittal balance has to be taken in consideration. Another recommendation is posterior surgery can achieve satisfactory kyphosis correction with less blood loss and complications. Long constructs are superior than short segments, and intermediate screw strengthens the constructs. Thank you so much for listening. So this is, let me stop share. So Nikolai, are you ready?
Yes, I'm ready.
So the indications for surgery, non-surgical treatment for thoracolumbar. Nikolai, please go on.
Thank you. Let me share my screen. Hello, everybody. Pleasure being with you and honor being with you today. As Onur announced, I'm going to talk to you about the non-surgical and surgical indications for thoracolumbar trauma. So despite intensive development and refinement of the contemporary protective equipment and algorithms implemented in working environment, in modern vehicle, trauma still represents a very major killing factor and a very big causative for morbidity. That's why we keep discussing it. That slide tells you that about 20% of the trauma will be complicated with neurological injury. About 70% of the fractures are due to motor vehicle accident, and up to 80% of the thoracolumbar fractures will be treated conservatively, provided they have no neurological deficit. So the problem of how to treat trauma always stands. And one of the main questions is to fix or not to fix. So if I give you that, that MRI scan of a patient, I'm sure that anonymously all of you will say that, or majority of you, I'm sure, will say that this is something that needs to be treated surgically. If I give you that X-ray, however, probably majority will choose to treat that patient conservatively. So there is areas of discussion and there is areas of no discussion. I guess no discussion will be if we have a fracture dislocation, all of us will decide to treat that with surgery. Or if we have significant instability with neurological deficit, then no question, the majority of us will treat that with surgery. But it's still controversial if we have burst fracture without neurological deficit, or even any fracture without neurological deficit. So that's why we are discussing and keep discussing. And usually if it's a controversial topic, there is a lot of written about it. If you go to PubMed and if you write thoracolumbar trauma surgery, you'll see many, many articles. And different articles will give you different outcomes. So you see that article from Shen in 2001 is telling you that the outcome is similar in 2 years if you treat your thoracolumbar injury without neurological deficit with surgery or without surgery. Sibanger, however, later on tells you that actually it is better with short segment. Then Wood again is telling you that there is no difference. And then Landy again is telling you that patients are more satisfied with surgery. But then Medici is telling you that actually that's not true. So it is constant topic, and it's topic that is constantly discussed. And so the conclusion that we are making is that the operative management of thoracolumbar burst fractures without neurological deficit, it is possible, according to the literature, to improve the kyphosis, but does not appear to improve pain function at 0.4 years after surgery, and could be associated even with higher complication rates, higher cost, that for sure. Another conclusion that you can do if you follow the literature is that we need more evidence. We need more evidence to further classify the appropriate burst fracture that will be for conservative treatment. And probably we have to include or clarify more variables in order to decisively conclude for one or the other. So this is recommendations that were published from the American Association of Neurological Surgeons. They have actually reviewed the literature exactly the way how we did, and recommended that there is no convincing evidence that suggests that the burst fracture without neurological deficit should be treated surgically or non-surgically, and they left that to the discretion of the treating provider. Also, they say that there is insufficient evidence to recommend for or against use of surgical intervention for non-burst thoracic or lumbar fractures. So again, this was left to the discretion of the treating physician. Classifications. We try to use the classifications in order to guide us how to treat our patients. So the ideal classification will give you ideally guidance without doubt how you treat a specific patient with or without surgery. What surgery do you use? Also, the ideal classification will allow you to talk to your colleagues without any doubt, without any reasons for miscommunication. Unfortunately, we still don't have that ideal classification. Jamal was very good presenting all the different classifications. I'm going to mention just two of them, AO spine and the classification that was published by Vaccaro. So speaking about area classification, that's one of the most comprehensive classifications, had already a few revisions. However, it's still away from perfect. You can see that research is telling you that if you evaluate the inter-observer reliability of the AO and compare with a very simple one, which was Dennis, for example, you'll see that Dennis has higher inter-observer reliability comparing to AO classification. And this is because it's very, very comprehensive. It's very complex. It is difficult for everyday use. And that is why that creates gaps and that creates miscommunications. So despite all that, it is still widely used classification, and it's still a good classification. And anonymously, most of the users of the AO will tell you that if it's a type A classification, most likely you'll be possible to treat that with conservative measures. And on the other hand, most of the users will tell you that type B, which is destruction injury, and type C, which is translation injuries, most likely will be treated with surgical solutions. Of course, there will be exclusions of that. Of course, there will be variations of that. But the mainstream will be this. Type A will be mostly conservative. Type B and C will be mostly surgical. The other classification that I mentioned to you is Vaccaro's classification. It is also very popular and is also widely used. But again, it is not perfect and is not giving us all that we need. Based on injury mechanism, based on the condition of the posterior ligamentous complex, and based on neurological status, and that gives you positives and negatives. And the negatives of this will be that the injury mechanism, although presented and although reflected in the classification, is not as comprehensive as with the AO. Then if you have to evaluate the posterior longitudinal, the posterior complex, the ligamentous complex, you need an MRI scan, which sometimes might not be available in some centers or might not be available in out of hours. And trauma happen all the time. So you need 24/7 MRI service, which is not the case in some of the centers. Then if you would like to have a proper neurological assessment, you may need to have a awake person and responsive patient that is cooperating, and this might not be the case in all of the trauma, especially in the multi-trauma scenarios. So in order to supplement the Vaccaro's classification, McCormick published another classification, which is giving you guidance of how exactly to treat your patient in respect of anterior versus posterior or combined approach. Based on the combination of the fragments, position of the fragments, and reducibility of the sagittal deformation. And it's again a point system. If your patient gets a score 7 or higher, then you may consider going anteriorly, or at least think of support of the anterior column if you have any means of doing that with posterior approaches. So shortly about the surgical treatment, and shortly now about the non-surgical treatment. The options, if you would like to treat your patient conservatively, would be analgesia, bed rest. You can try close reduction. You can try bracing. Do we have level 1 evidence about non-surgical management of thoracolumbar trauma? Yeah, we do have some, not many, as with anything that we do in medicine. However, still, a good level 1 evidence, Canadian study that is telling you that you can treat your patient with or without brace with no difference of the end result. So the Canadians are telling you that, yeah, you can use a brace if you feel comfortable doing that. However, that's not going to help you much. There is another study, which is still strong study, level 2, that comes from the United States, and that is telling you more or less similar. But what's important and what's interesting in that study is that significant shorter length of stay with the patients which are treated without a brace. We can discuss that, and we can even speculate why is that. But this is another topic, and I'm not going to continue with this now. So bracing versus no bracing, again, multiple level 4 studies. So the conclusion of the Congress of Neurological Surgeons in 2019, which reviewed the available literature about this, was that you can treat your patients with brace if you would like to, if you decide to treat them conservatively. That's not going to contribute for a better result, and it is not harmful. So if you still feel, if you still like the brace, you can use it, but it's going to be no harm for your patient, and it's going to be no benefit. This is the final conclusion that they have done. So as part of the work of the WFNS Spine Committee, we also have published recommendations which are treating the problem thoracolumbar trauma, conservative versus conservative versus surgical treatment. I'm going to skip through them fast because they have been already, most of them have been already pointed. So fracture dislocation and cases with significant instability obviously should be treated surgically. Significant surgical decompression and stabilization should be considered for burst fractures with a neurological deficit, although we still need more research to support that. Burst fractures without neurological deficit can be treated either with conservative or surgical techniques. And as most of the research suggests, and our conclusion as well, this is on the discretion of the treating physician. AO type B and C fractures mostly will be treated surgically. AO type 2, AO type A fractures mostly will be treated with conservative measures, unless there is significant body collapse, significant kyphotic angulation, or canal compromise with neurological impairment. And finally, there is no clinical evidence that suggests that bracing for conservative treatment of thoracolumbar fracture will improve the outcome. And that was it shortly from me. Thank you so much for your attention.
Thanks a lot, Nikolai. Very nice lecture, really. Now I will invite Dr. Sandeep Vaishya to give a talk on outcomes of spinal cord injury. Sandeep, you must unmute yourself. Sandeep, unmute, please.
Yeah.
Okay, good.
Can you see my screen?
Yeah.
Hi, Mehmet. How are you?
Good. How are you?
So I'm a late entrant because I was told about this talk today morning only. So I'll just start with some prognostic factors in the spinal cord injury. So traumatic spinal cord injury, as we all know, is a very devastating event which can lead to death or lifelong disability. And usually younger people are more commonly affected. It leads to loss of productive life years and, and has an enormous economic and social impact on the patient and their families. Cervical spinal cord is the most commonly affected, and usually it is much more devastating as compared to thoracic injuries because the patient is dependent on others for his day-to-day activities. For these patients, the ability to walk again is of extreme importance and is the desired result for both the patients and the physicians. The improvement of motor power has become the main goal of pharmacologic and rehabilitative interventions in the modern era. So based on the parameters from international standards, physicians may be able to inform patients about the predicted long-term outcomes, including the ability to walk with very high accuracy. So the adjuncts to these things are magnetic resonance imaging, biomarkers, and electrophysiological examinations.
Can you make it whole screen? Whole screen?
Oh, it's just
whole screen.
Just 1 second. I don't know, where's that button gone? Just give me 1 sec.
It's on the top, Sandeep.
No, I know it's on the top.
Yeah, that's it. That's it.
Yeah. Okay. So aggressive cardiopulmonary management and surgical intervention of patients with spinal cord injury have also been shown to improve outcomes. So timing of surgery, does it matter? 10 to 15% of patients with Asia A grade lesion convert to Asia B to D. However, only about 3% regain functional strength below the lesional level. But almost 54% of individuals with initial sacral sensory sparing, which they were Asia B initially, they gain substantial functional strength below the lesion and will convert to Asia C to D. 86% of those classified as Asia C to D at 72 hours regain useful motor function. So evidence suggests that persistent compression of the spinal cord after the primary injury represents a reversible form of secondary injury, which if corrected may lead to reduced neural tissue injury and improved outcomes. So early patient mobilization in institution of physical therapy and rehab is another benefit. So based on biology of spinal secondary injury and spinal cord injury, the spine trauma study group has operationally defined early intervention as occurring within 24 hours. This was in an article published by Dr. Fillings. So for early surgery, the early stabilization highlights the concern of worsening spinal instability, and we should stabilize the patient as early as possible, either by surgical approach, or in some cases where you cannot operate the patient for some reasons, then by applying halo brace or traction. So there have been several studies on this topic. So this was a study published by Blamel et al. And they differentiated between the early and delayed stabilization in severely injured patients with spinal fractures. And they collected data from the Trauma Registry and the German Trauma Society. They compared early, they defined early as less than 72 hours versus late, that was more than 72 hours. And they found that the early stabilization was associated with a shorter length of stay, shorter ICU duration, and reduced rate of sepsis compared with those patients who were operated late. Now, impact of timing of surgical intervention, cervical spinal cord injury. So Barasa et al. Observed significant benefit of surgical decompression within 24 hours. So 9 out of 14 patients in early group improved at least 1 grade as compared to none out of 6 in the late group. Again, Hansbaut et al. Evaluated the effect of early surgical decompression in combination with perioperative regional epidural cooling within 8 hours of injury. And then 9 out of 14 patients with complete cervical cord injury improved by at least 1 Asia grade. In a recent meta-analysis, benefit of early surgery within 24 hours were investigated, and an increase of 2 Asia grades was regarded as successful. Improvement in the early surgery group was 22.6% as compared to 10.4% in the late surgery group. So this indicates a paradigm shift in the surgical treatment of the patients with complete traumatic spinal cord injury, which should not be, and they surmise that it should not be treated less urgently than the patient with an incomplete spinal cord injury. So 3 studies specifically evaluated the thoracolumbar spinal cord injury and the timing of surgery. So one study in patients evaluated the effect of surgery within 8 hours. So 5 out of 6 patients with complete thoracolumbar fractures with Asia A improved neurologically. 1 improved to Asia B, 1 to Asia C, and 3 to Asia D. So this suggested that an very early surgery relatively improved the neurological status of these patients. So this is a chart showing various studies, and most of them showed that early surgery improved the Asia outcome in the patients as compared to late surgery. There was this article about differentiating between the ultra early surgery versus early surgery on the functional outcome of the patients. So Nasi et al. Observed that patients who were operated ultra early benefited more than the early surgery patients. Ultra early surgery was defined as surgery done within less than 12 hours of trauma. And lower complication rate for ultra early surgery versus early surgery patients was seen, and it was attributable to the increased susceptibility and nutritional compromises as compared to those undergoing the delayed procedure. So there was certain recommendation by the STASIS trial, which was published in 2012. And they opined that decompressive surgery prior to 24 hours after spinal cord injury was performed safely and were associated with improved neurological outcome. And they defined it as at least a 2-grade-ish grade improvement at 6 months follow-up. So basic thing was that the surgery was safe and the neurological improvement was much better than the late group. So there are certain patients who, apart from spinal cord injury, they may be having polytrauma, which may be affecting the hemodynamic stability and other factors. So they observed 340 polytrauma patients with an injury severity score of greater than 16. It was done at a single level 1 trauma center. And they had a protocol termed early appropriate care, which emphasized operative treatment of various fractures within 36 hours of injury. And their opinion was that the early surgery was much more beneficial than a delayed surgery. So this was the systematic review comparing the timing of decompression in patients with acute spinal cord injury. So their conclusion was that there was improved neurological outcome amongst cervical spinal cord injury patients undergoing early surgery. That was in less than 24 hours. But in other spinal cord injuries, that is thoracic or thoracolumbar, the findings were inconsistent. So for cervical cord injury, the findings were pretty definite that early surgery was beneficial. In complete traumatic spinal cord injury, spontaneous neurological recovery in patients with complete injury, it differs per level of injury. Surgical decompression within 24 hours has a beneficial effect on neurological recovery in patients with a complete cervical injury, whereas the effect is less clear for thoracic and thoracolumbar injuries. This was same as the previous study. So this was a study from Germany, and they found that early decompression led to better sphincter and functional mobility in patients at the end of 1 year of follow-up. So there are 2 randomized controlled trials in the literature comparing early versus late stabilization. They had small sample sizes and were not designed to answer questions about the management of polytrauma patients. And the confounding variables included surgeon expertise and scheduling conflicts, as well as individual surgeon bias regarding preference for early or late stabilization in spinal trauma patients. So surgeon bias and the factors of that particular hospital or setup may have a problem. So ultimately, what should we do? So we should be aggressive, but we should be sensible also not to harm the patient. So according to the best available scientific and clinical evidence, we believe that surgical stabilization, if needed, should be performed as soon as possible, particularly for unstable cervical or thoracic spine trauma, within the constraints of the patient's overall medical condition. So the factors that we have to consider are the hospital setup, the availability of general surgeon, intensivist, emergency ICU and operation theater availability, the quality of nursing care, and your own experience with management of such complex patients. So for future, the prospective randomized multi-center clinical trials are warranted to gain valuable data and helpful management algorithms for patients with spinal fractures and polytrauma. Now, cardiopulmonary management of spinal cord injuries. Various studies have shown that improvement of blood pressure is very important. So this was studied by Levy et al. And they studied 50 acute cervical spinal cord injury in ICU at the University of Maryland. So 82% patients had hypotension, required pressors within first 7 days. The requirement of vasopressors were 5.5 times more common in patients with complete motor injuries. 40% of patients, including complete injuries, had neurological improvement. 42% remained unchanged, and 9 patients died. So hemodynamic monitoring in the ICU allowed for early identification and prompt treatment of cardiac dysfunction and hemodynamic instability. And thus it can reduce morbidity and mortality. So aggressive cardiopulmonary resuscitation. So this was one of the early studies on that, and Vail et al. In 1997 examined 77 spinal cord injury patients, and they treated them with volume resuscitation with pharmacologic blood pressure, and with the goal of keeping the mean arterial pressure above 85 millimeters of mercury. 92% patients with incomplete injury showed improvement, while 42% patients with complete spinal cord injury showed improvement. So they also point that the aggressive cardiopulmonary resuscitation efforts result in improved neurological outcomes in patients with acute spinal cord injury. So again, this was the meta-analysis of blood pressure management after spinal cord injury. And the conclusion was that there was significant evidence that hypertension with neurological injury results in poorer outcomes. So the level 3 recommendation was the correction of hypotension in spinal cord injury. That means keeping the mean arterial pressure above between 85 and 90 for the first 7 days improves the recovery rate of the patients. So Harluk et al. In 2015 published a study, and they elevated the mean arterial pressure during the first 2-3 days following injury, and they found that it improved the neurological outcomes. Now, what about the intrathecal pressure? The spinal cord perfusion is inversely related to the intrathecal pressure. So it has been proposed that elevated intrathecal pressure following injury may also lead to decreased perfusion and increased secondary injury. And if you decompress the spinal cord, it will decrease the intrathecal pressure and thus improve the perfusion of the spinal cord. So Consortium for Spinal Cord Medicine, they published a study in 2008 on early acute management of adults with spinal cord injury. Again, they describe the drugs which can be used for hypertension. So in cervical or high thoracic lesions with both hypotension and bradycardia, a drug with chronotropic and inotropic effect as well as vasoconstrictor properties might be required. So norepinephrine or alternatively dopamine could be good options. While in low thoracic lesions where hypotension is usually the result of peripheral vasodilatation, a pure vasopressor drug such as phenylephrine could be appropriate. Now, a few slides on the importance of radiology in prognosis of spinal cord injury. As we all know, MRI can show the anatomy of the spinal cord in great detail and can be a good prognostic factor. So MRI imaging should be obtained when feasible in the first 48 hours after the trauma. In our center, we do it in all spinal cord injury patients in first hour. It is also a valuable tool to classify severity and predict the outcome based on the presence of hemorrhage, extent of edema, and severity of initial compression. While a normal initial MRI image is usually associated with complete recovery. So how does radiological prognostication help? Why would it help us? So firstly, it can predict functional outcome, which can influence the rehabilitation strategies for the patient. There can be better understanding of the degree of neurological improvement in some patients who have concomitant head injury, and it's very difficult to examine them. So in the presence of or the degree of injury in the spinal cord can help in prognostication and assessing the extent of injury in these patients. So thirdly, in children, clinical examination sometimes is quite unreliable, and so MRI can also help in prognosticating in these children. So what is the impact of facet dislocation? So in this study, in 421 patients, 135 patients had facet dislocation and 286 had no facet dislocation. So compared with patients without facet dislocation, patients with facet dislocation tended to have a more severe degree of initial injury and displayed less potential for motor recovery at 1 year follow-up. That just suggests that if there is facet dislocation, then the injury can be more severe.
So can I come to conclusion?
I think just 2-3 more slides. So this was a basic score. I'll just show this. So it can also help in prognosticating the injury. It just in the axial cut where there is a maximum injury. So you see the amount of changes in the gray matter, whether it extends the gray matter, whether there are hemorrhages also. So the basic 4 would have the worst outcome. And the basic score has an excellent prognostic potential across all spinal cord injuries. I'll just skip these slides again. So again, just a couple of slides on diffusion tensor imaging is an upcoming thing in spinal cord injuries and can be a more sensitive biomarker for spinal cord damage than just plain T2 images. So again, these are papers on diffusion tensor imaging. Functional MRI is still, there are few studies on functional MRI, but again, they were non-conclusive, but they could find neural activity across all patients with any kind of severity of injury. So the presence of facet dislocation is suggestive of a poor neurological outcome. T2 MRI is an acceptable method to rapidly screen patients. So DTI may be helpful, and the basic score provides best and easy means to predict outcome. So these are the ongoing researches and interventions. And to summarize, knowledge of new and emerging prognostic factors may assist us to direct our efforts towards focused aggressive therapeutic interventions, which may present a more promising result for spinal cord injury. Thank you.
Thank you, Sandeep. It was great talk. Although you said I started preparing this morning, and it was great, really. Thank you.
I was operating whole day. I just came home half an hour before the talk.
Okay, that's fine. Great. Now, the last talk will be given by Dr. Toshiro Takami on the very discussed topic, pharmacological and regenerative cell therapy for spinal cord injuries. Dr. Takami.
Yes, can you see my slides?
Yeah. Please make it whole screen.
Yes, it's okay.
Good. Very nice.
This is Dr. Takami from Osaka, Japan. Thank you very much for giving me this kind of opportunity. And it is so nice for me to join this webinar. So my topic is the pharmacological and regenerative cell therapy for a spinal cord injury. And I started from the first topic, the pharmacological therapy for a neuroprotection after an acute spinal cord injury. And so we, WFNS Spine Committee, published this review article 2020 in Neurospine. And we focus our attention to pharmacological regenerative cell therapy for a spinal cord injury and to make a WFNS Spine Committee recommendations. And so we did the PubMed research, and finally we selected 93 papers, and we carefully reviewed to make a summary of the published clinical trials of the major pharmacological therapies for acute spinal cord injury. So I can show you the one by one. The first is the methylprednisolone. So this is, the synthetic corticosteroid with potential anti-inflammatory and neuroprotective effects. And the National Acute Spinal Cord Injury Study, what we call NASCIS, they did 3 big clinical studies, try to make the clinical benefit of the methylprednisolone for a patient with acute spinal cord injury, NASCIS 1 and NASCIS 2 and NASCIS 3. And however, there were the significant concerns about the statistical analysis, randomization, and the clinical endpoints. And so Harvard later carefully labeled the published result from the NASCIS 2 and 3 in the context of the original study design, including primary outcomes compared with post hoc comparisons. So finally, they published their recommendation regarding the use of the MP for a patient with acute spinal cord injury. So the high dose MP is not recommended, and there is no class 1 or class 2 medical evidences. Finally, harmful side effects are including death. So our spine group, they did a similar statement, and they suggested not offering a 24-hour infusion, the high dose MP, to the adult patient who presented after 8 hours with acute spinal cord injury. And they suggested a 24-hour infusion high dose MP to be offered to the adult patient within 8 hours of acute spinal cord injury, but this is a treatment option. And they suggested not offering a 48-hour infusion high dose MP to the adult patient with acute spinal cord injury. So next is the RAW inhibitor, what we call cecilin. So this is a recombinant inhibitor of the RAW that is mainly involved in the control of the cytoskeleton and has been shown to promote axonal outgrowth inhibitory substrate both in vitro and in vivo. So there are 2 major clinical trials using the RAW inhibitor. However, those studies, they finally failed to show the statistical significant difference between the treatment and placebo control groups. So next is the minocycline. So minocycline is the tetracycline antibiotic with the neuroprotective and anti-inflammatory properties. And so this is the phase 2 placebo-controlled randomized trial using a minocycline for a patient with acute spinal cord injury. And so minocycline was started within 12 hours and continued for 7 days. And so the result tried to show the beneficial effect and the trend toward improved motor scores in complete cervical spinal cord injury, so that the result was partly positive for incomplete spinal cord injury patients. And the phase 3 randomized control study using minocycline for acute spinal cord injury. And this study had to be halted due to poor patient enrollment. So next is the riluzole. So riluzole is the benzodiazole that inhibit the voltage-gated sodium channels and the glutamate release, so thereby the mitigating excitotoxicity, and it can be used for the treatment of amyotrophic lateral sclerosis. And this is the prospective multi-center phase 1, the study tried to show the safety and the efficacy of the riluzole. This result was published in 2014, and the result was partly positive for incomplete cervical spinal cord injury. And this is another study, the phase 2B and 3 trial using a riluzole. And so riluzole was studied administered orally within 24 hours after injury and continued for 14 days. And the study is estimated to be completed by 2021, but now extended by the 2025. So this is the GCSF. So GCSF is the major growth factor for the activation of the differentiation of the granulocyte colonies in the bone marrow. And so Japanese group, they did the multi-center prospect study, but not randomized. And so they showed just a modest motor score improvement 1 year after injury in the treatment, the group of the GCSF. And the same study group was, they did the randomized trial using a GCSF for the spinal cord injury. And they recruited 43 patients of the GCSF treatment and the 45 patients of the placebo control group. And so primary endpoint at the 3 months after surgery, there was no significant difference in the primary endpoint between these two groups. And so finally, this study, they failed to show the significant effect of GCSF in the primary endpoint. So finally, systemic hypothermia. My project, Levy, they try to have the modest intravascular hypothermia therapy for the very severe complete injury, AIS grade A, and all patients were treated with 40 hours injury, 40 hours of the modest 33 degrees Celsius intravascular hypothermia. And so they found that no adverse effects compared to the control group. So that the systemic hypothermia in the acute spinal cord injury focused on the AIS grade A to C, and the study is estimated to complete it by the 2023. So finally, this is our recommendations regarding pharmacological therapy for acute spinal cord injury. There is not good evidence that a high dose MP, a high dose 24 infusion for acute spinal cord injury is beneficial in correlation with its high rate of the complications. In selected young patients with acute spinal cord injury, 24 infusion high dose MP administered within 8 hours may be suggested. And against acute spinal cord injury, there is no pharmacological agent with high level evidence that can be actually can be administered. So next topic is the cell therapy for a neuroregeneration after spinal cord injury. So this is a summary of the possible cell sources of the for transplantation in injured spinal cord. The first is the Schwann cell. So Schwann cell can be harvested from the autologous peripheral nerve, and so expected to have the axonal regeneration and the sprouting and possible myelination. And the olfactory cells can be also obtained from the autologous olfactory mucosa, and expected to have axonal regeneration and the sprouting as well. And the mesenchymal stem cell can be obtained the bone marrow and expected to have the neural differentiation, myelination, circulation of the trophic factors. And the neural stem cell can be obtained from the brain and spinal cord and expanded for the transplantation, and expected to have a neural differentiation, myelination, and the circulation of the trophic factors. So finally, induced pluripotent stem cell, what we call iPS cells, can be expected from the human cells, and the expect to have the neural differentiation, myelination, the circulation of the trophic factors. And I can show you one by one. This is the Schwann cells. So this phase 1 safety trial of autologous human Schwann cell transplantation for a chronic spinal cord injury, and so published very recently. And so they try to have the dural nerve first, and the dural nerve harvest, and the Schwann cell, they were isolated, propagated in culture, and the culture that expanded the Schwann cell were injected into the chronic spinal cord lesion of the adult patients, and followed by the cavity filling a volume approach. And so they showed that no serious adverse events related to the dural nerve harvest or Schwann cell transplantation itself. And follow-up MRI and finally revealed the reduction in the cyst volume after transplantation with a reduced effect over time. So that this phase 1 trial demonstrated the feasibility and safety of adult Schwann cell transplantation, and combined with the rehabilitation protocol for a patient with chronic spinal cord injury. And this is the first trial of the olfactory enzymatic glia transplantation to the spinal cord, human spinal cord injury, published in 2005. And as you know, more than 10 clinical trials have been completed demonstrating the safety and the feasibility of the olfactory enzymatic cells transplantation for the spinal cord injury. And and the meta-analysis said that the more than 1,000 cases across the several clinical trials found no increase in the serious events. However, efficacy could not be determined due to the methodological technical concerns. So next is the mesenchymal stem cells can be obtained at the bone marrow. So this bone marrow derived the mesenchymal stem cells transplantation seems to be feasible, safe, and have a good degree of the outcome improvement. So there are several clinical studies, and so most of the studies they show the very promising results, but more qualified randomized control trials should be conducted to examine the efficacy and the appropriate dosage of the mesenchymal stem cells. So this is another way using mesenchymal stem cells. So this group will try to have autoserum expanded and mesenchymal stem cells, and they try to have intravenous injection, not the direct transplantation to the spinal cord. And so this study was unblinded and does not exclude the placebo effect of the contribution of the endogenous recovery of observer bias, but the study results provide evidence supporting the feasibility, safety, and functional improvements in some extent. And finally, this trial, intravenous injection of mesenchymal cell therapy was approved by the Japanese government very recently. And this is neural stem cells, human fetal brain derived stem cells. And so there is one concern about the tumor genesis in the transplantation cavity, but there was no significant increase in the rate of the serious adverse event with escalating dosages. And the safety study of the human spinal cord derived neural stem cell transplantation for the treatment of chronic spinal cord injury, phase 1 open label single site safety study is now underway. And this study is estimated to be completed 2022. And finally, I can show you the induced pluripotent stem cells, what we call iPS cells. And in February 2019, the Japanese government had given the permission finally for a trial of human iPS cells to treat spinal cord injury. So the researchers at Keio University plan to have recruit 4 adult patients of the spinal cord injury, and the study is now underway. So this is a recommendation regarding the cell therapy for the spinal cord injury. Although some of the cell sources can be expected for the beneficial effects, we are not able to make any recommendation regarding the efficacy of the cell therapy for spinal cord injury. Thank you very much for your kind attention.
Thank you, Dr. Takami. Very nice information, especially in that challenging area of regenerative therapies. Now we came to the discussion, and then we will see 2 case discussions afterwards. Although some questions are answered by Salman, I will start with some open questions. What is the neurological outcome after surgery of kyphosis? Dr. Abdülhafit Bajamal, do you wish to answer that? Abdülhafit?
Remember, that question might be for owner, but owner is.
I think it's okay. The kyphosis is that's why the important thing is the diagnosis before treatment. So the 15 cup angle more than 15, it is indication for surgery. But that's also we have to include other evaluation, and the result is depend on what kind of treatment you use. Short segment fixation, many explain about the possibility of failure if you don't use extra screw in the injury level. And some treatment said that if you do treatment of the short segment better, you give the best one is to give kyphoplasty and inserted also the screw in that level. That is the best way to make the anterior part is strong enough for prevent the further kyphosis.
Yes, I can just give an answer that the outcomes are better if the neurologic deficit is not too much. If it is very severe, outcomes are not good. But so then we must not wait till the patient becomes paraplegic.
Actually, Prof. Zilele, actually there are many factors can affect the result of kyphosis because it consists also from the bone metabolism. So the effective way is to observe the patient minimally 2 years because.
But the question is neurologic outcome, not the others actually.
Neurologic
because of
outcome.
that I said. Yeah, just neurological outcome. The question.
Yeah.
Thank you.
Okay.
Are we getting the quiz questions? No, this meeting has no quiz questions. One question is facetal dislocation reduction. Do you advise anterior or posterior? Do you want to answer, Salman?
Yeah, as I had actually shown in 2 slides, and after me, I think Francisco also showed this as well. I think Sandeep also showed that obviously you can do this anterior or posteriorly. It depends on if you're doing it awake. If the patient is awake, intact, then obviously you can do that close reduction, and you really then you can go in anterior, posteriorly, whatever you like, but ideally anteriorly, and just simply fix afterwards. But there are specific indications for anterior and posterior if you are doing a open reduction. And obviously, majority of the time, it is reasonable if the duration of facet dislocation has been short, then you should be able to do this anteriorly, and it's very simple. If you have an MRI, then it's quite good. On the other hand, there are problems with anterior approach, which is dysphagia and as well as swallowing problems, and in some case hoarseness. And you need to be wary of that. On the other hand, posterior approach it has got advantage. The disadvantage is a higher risk of infection, and there is severe pain when you go through all that muscle. But at the same time, you can do that once this fracture dislocation is chronic, that is more than 10 days or 2 weeks, then it's probably best to go from posteriorly, take down the facet and open it up and then distract. There are other ways of doing it as well, but the most important thing from the perspective of a disc or a bony element sticking in there is in patients who are not awake or you're not able to evaluate, obviously you need to have an MRI beforehand before you go in anteriorly in those. But generally speaking, acute, you can come from front, chronic, you can come from behind, because nearly always you can reduce it from anterior.
Yeah. In chronic cases, it's better to make a facet resection in chronic cases after 2 weeks mostly. A facet resection first, then turn to anterior and then make anterior fixation. Yeah. One question is that you did not mention the importance of neurophysiologic studies in the diagnosis and prognosis of spinal cord injuries. What do you think about it?
Sandeep, that's your question. Sandeep.
Yeah. Sandeep, is there a predictive value of neurophysiologic studies?
Sandeep, unmute, please.
Unmute, please. Sandeep, unmute.
Yes, they do have some predictive value, particularly in early injury cases. Though we don't do routinely as soon as the patient comes, we do it in a slightly delayed manner. After a few days, would be the first time when we would do those. And yes, they have some predictive value.
Obviously, we know if the motor power is less than 2, then the reliability of that nerve conduction study EMG is not as much as if the motor power is more than 2. So we need to be careful about that.
I was talking about more of SCPs in patients with complete injuries, whether we can get any signal or not. So.
Okay. Personally, I don't trust the value of electrophysiologic tests. The value of your neurologic scoring is much more than anything else. Second thing is probably a new MR techniques like diffusion tensor imaging or that basic scoring. They have really very predictive values. But is there any level 2 evidence for regenerative therapeutics? Is there any treatment approved? Dr. Takami?
As far as I know, there is no good the level 2 evidence for a regenerative cell therapy. But the intravenous injection of autologous the serum expanded the mesenchymal stem cells was already partly covered by the social insurance in Japan. So I don't know there is no other good the cell therapies in the world.
Okay, thank you. One question is, could you send us the slides? Unfortunately, we cannot do it. We will, however, place the video recordings of the meeting on the website. Salman?
Yes, I think they're available
Yeah.
on the website afterwards. So you can access WFNS Spine Committee website, and I'm sure those docs will be there. We will request Nasser to share with us, and I'm sure we can share it on the YouTube channel.
Of course, it was great pleasure.
The other thing is that there are actually all the studies regarding all these regenerative therapies there is no standard study available, class 1 or class 2, which tells us that really they work. And there are small case series that people are showing their results.
Okay. Are there any questions from the speakers?
Yes, Mehmet, perhaps I can just make a comment on
Please.
the facet dislocation approach, anterior versus posterior. It's of course a
Please.
a very
Please
nice
do it.
topic, but there's a very practical thing about if you've got very limited theater or operating time access. So sometimes in a very high volume service such as ours, to do a posterior fixation, if you don't have a decompression that's looming, it saves you a lot of time. It's a one-stop shop. You can relocate the facet joints, fixate it, and be out in a short amount of time. So although should not be your primary consideration, from a very practical point of view, that is certainly something that appeals a lot to us. You know, the whole front, back, front, or frontal failed reduction, turning around, we know this can turn out into a 5-hour endeavor with all the turning and logistics. So often that is just a very appealing approach to particularly our environment, where we need to get as many done as possible in a short amount of time.
Yes, thank you. Any more questions? If there is not, so we can come to the presentations, case presentations. We have 2 cases. First one will be presented by Dr. Mirza Pochzik, a cervical trauma. Mirza?
Yes. Good afternoon to everyone. Can you hear me well?
Yes.
Okay.
Please share the screen.
Yes. Okay. Can everybody see well? I hope it's all right.
Yes.
Okay. So good afternoon. First of all, I would like to thank the organizers for inviting me to be presenter at such a good webinar. I've followed webinars prior to my function as a member of WFNS Spine Committee, and I want to thank to Professor Sharif and Professor Gandour and Professor Zileli and Yaman for this big honor to present here a case as a novel member of our spine community. My name is Mirza Pochzik. I am a neurosurgeon from Philipps University, Marburg, Germany. I know here says professor. I'm not yet a professor, but I'm on a best way of achieving that. So I just wanted to say that in front for disclosure. I work for several years now in Marburg, and I'm doing primarily spine surgery. And I wanted to present one case which gave us a lot of headache, and which is one of these cases where you see that all classifications and everything what we talk about is actually very valuable, and is something you need to know and appreciate when dealing with such a case. We had a 62 years old patient who was actually who has fell from the height of 2 meters under influence of alcohol. That was a patient with adiposity, I think 140 or 150 kilo, and with high blood pressure, and who presented with a neck pain as well as pain in the cervicothoracic region of the spine. he was not able to sit or stand up. He had a C7 radiculopathy on the right side, but actually no motor deficit. He was very severe to handle due to his alcoholism and adiposity. And what we got from the external hospital, which referred the patient to our center, was this X-ray of the spine. It was, it said no fractures or no pathology, but they immobilized it with stiff neck and referred it to the tertiary or to the higher center. So you see here in German language, it says erschwert im Liegen. That means that the X-ray has been done under very severe conditions in the lying position, because the patient could not lay down, he could not stand up, and he could not sit. He was just in one not physiological movement all the time, because he had severe pain on the neck and upper thorax. So we performed the CT of the cervical spine, which we actually do always by a protocol in every patient which comes with a trauma. Of course, we're a university hospital and we have that capacity to do CTs of head and of cervical spine 24/7, which I'm aware of is not the case everywhere. And in this first CT, which you can see is full of artifacts and not really good to set a diagnosis and to decide what to do further with this patient, we saw that his 7th cervical vertebra had a fracture of the posterior wall. There was also CT angiography to exclude the vertebral dissection, but on this photo on the total on the right, you see that there are a lot of so-called Aufhärtungsartefakte which prevent to do proper assessment of the cervicothoracic region. So we did another CT scan when the patient was actually a bit calmer. He moved all the time and he needed to be sedated. And in this further CT scan, we've seen actually two further crucial and important injuries, which then led us to our treatment algorithm. We've first seen that the spinous process above the C7 has been fractured, but also, and that's crucial and important, the arcus on both sides of the C6. So we had from an initially radiologically no signs of fracture to the CT, where we have seen that the patient has actually a free column fracture, the fracture of the posterior wall, the fracture of arcus, and the fracture of the spinous process. We have also did an MRI, which we usually do in fractures, either it's acute or chronic. And the MRI has shown that the patient has actually fracture, very severe fracture of the C7, which goes from the entire through the entire disc, so a traumatic disc fracture, and that he also has, as you can see on the slide on the left, small epidural hematoma. So during the first hours at admission at our hospital, he developed from having a C7 radiculopathy on the right side, paralysis on both upper and lower extremities, so that we decided not to wait with surgery. He presented maybe around 2 or 3 in the morning from the tertiary center, and we did the surgery the next day. We have decided to perform as our initial step, well, the plan was to perform a 360 stabilization, so to do from anterior and posterior, and I'm going to explain later why was that decision. And if we look at everything what we heard, Professor Costa had a great talk on subaxial cervical spine injuries, and our committee has also issued guidelines on treatment of these fractures. If you look at this complex fracture of a anterior, middle, and the posterior column, then it is actually reasonable to do the anterior and posterior surgery. There was also a discussion whether to do the anterior or posterior surgery first. And due to this prevertebral hematoma and due to the movement of the C7 and the ruptured cervical disc, we have decided first to do the anterior approach. So this is the intraoperative X-ray after performing corpectomy, C7. This is implantation of the expandable cervical spine cage. And the patient actually recovered very well following this first surgery, following the first hours after the first surgery. So his deficits also resolved, but on the next morning, he got up, left the hospital with the help of a friend.
You didn't place a plate?
We didn't place a plate. Yes, thank you. We wanted to place the plate, but because it was a cervicothoracic region and the patient had a very high sternum and was very adipose, we were not able surgically to place the plate from C6 to T1. We wanted to, but it was anatomically not possible to place a plate. And that was another treatment decision which led to, it was another thing which led to decision that we do this posterior stabilization too, because to put a cage without a plate is of course not such a good idea. Well, the patient next day vanished from the hospital with some drinking buddies, fell again, and then came again to our department and had this CT of the cervical spine, which is then shown that in a very short period of time following the initial surgery, his implant loosened or cracked the T1, which is actually an adjustment segment disease or a fracture of the adjacent segment. And what we also see is that there is an arrow. His epidural hematoma increased and he presented again with neurological deficits. So this is an adipose alcoholic patient, which was very hard to deal with from the beginning. The first surgery was performed classically under fluoroscopy control. So the plan was to do him anteriorly and then to do a second surgery in 2 to 3 days posteriorly. Also due to his anesthesiological condition, because he's had many concomitant diseases and surgery longer than 3 or 4 hours would lead him to intensive care unit. He also had some lung problems, which put him on the respirator for several days actually after the surgery. But we then decided to use the spinal navigation as well as for anterior and for posterior approach. Now, I'm very aware that navigation is not something which is broadly in use everywhere in the world, but our credo from the clinic where I work is to use the navigation anytime you can, because all studies in the last 10 or 15 years have shown that everything with navigation is, if you use it properly, is superior to the classical fluoroscopy. For people who don't have experience, of course, there are several studies which show that surgeons who have experience are actually quicker and have less malpositions with fluoroscopy compared to navigation. But for junior neurosurgeons, junior spine surgeons as me, if there is a possibility to do a case with navigation, at least in Germany, that's the case that has become slowly a gold standard. So that's what we did. We have that privilege that in our department, we have an intraoperative CT. So we performed as well as, these are the ICT views. So these are, we performed the one, so 2-stage, one sitting surgery. We did from the ventral, we performed another corpectomy. So we didn't do only corpectomy of C7, but half of the T1, which was fractured by the implant, repositioned the implant, and then put a very stable construct dorsally using cervical pedicle screws in C6 and C7, not lateral mass, but pedicle screws. And we also performed the laminectomy of C7 and T1 in order to evacuate the epidural hematoma. So these are the a part of the postoperative scans, where you can see on the left side that the plate placement was, we have tried it again, but it didn't work because of this very uncommon angle. And when the patient lies on his back, that angle gets even worse. So to put a plate here was just anatomically not possible. And we were thankful to have that navigation to put the cervical pedicle screws, which are, of course, especially in cases of non-compliant adipose patient, better than lateral mass screws. Now, Professor Costa had a great talk on our spine classification of subaxial injuries. So these are the excerpts from the original Vaccaro paper, which show the classifications from A to C. But I wanted to talk about two recent papers which occurred, one of them just on 3rd of December, so 3 weeks ago, where Sethi and colleagues in Neurosurgery Spine have published a review on 3-column injuries for the subaxial cervical spine injuries, where they analyzed 11 studies for qualitative analysis and quantitative synthesis of the data. And since there are a lot of experts, there are of course classifications and guidelines, but there are also gray zones where expert opinions sometimes disagree. And though no difference was found, anterior group had the maximum loss of correction, although the plate was used in all studies which favored anterior approach, and significant difference with most correction was achieved in combined approach subgroup in 360 fusion. And combined approach showed more operative time and blood loss, followed by posterior approach and anterior approach alone. There was a... Excuse me?
Please, go on. Yeah, okay. We must come to conclusion then.
Okay,
to discuss something.
Two slides more. Okay, there is also one recent review which compared fluoroscopic with navigation implantation of the cervical pedicle screws, which shown that misplacement rates of cervical pedicle screws was lower in navigation assisted compared to fluoroscopy guided techniques. And fluoroscopy guided techniques show the higher incidence of complication, especially related to neurovascular injuries. And this is one publication from our department. We analyzed the same thing, but in the upper cervical spine, but we compared the intraoperative CT with navigation, where we have shown the superiority of intraoperative CT navigation compared to the standard navigation procedures. And of course, I just wanted to, on the end, to show the recommendations of our spine committee. There has been some talk about it on that day, today, so I wouldn't talk about it more. And thank you for your attention, and I'm open to questions and discussion.
Thanks a lot. Very nice case. Yeah, really.
Thank you.
Can you please go to the please share the screen.
Okay. So it
go to the first
okay.
CT scan, sagittal CT scan of the patient. Yeah.
This
first.
one?
Yeah, previous. Good.
This
Stay.
one?
Yeah. This is okay. Yeah. But I guess, how old was the patient?
How old?
Yeah.
66.
66, yes. So then the diagnosis, this case is typical an adult idiopathic skeletal hyperostosis patient. Adult idiopathic skeletal hyperostosis. So then those patients can have whole spine fractures very often with a low height fall. They can just fall in front, and then the head goes in extension, and then it causes a whole spine fracture dislocation. It may be from the disc levels, because disc level is more weak point. Now come to the MR image.
Mhm.
The next one. Yes. And no. Yeah. As you can see here on the MR, it is disc level fractured also on the backwards, although the oblique fashion. So I would not do a corpectomy for this case, just a grafting and a plating.
Mm-hmm.
You could add a posterior fixation or not, doesn't matter. Because you have removed, although there is no compression from ventral, you have removed all the body, which is not a good thing. And any corpectomy may not be left alone because it then causes a iatrogenic instability, additional instability.
Mm.
So then my critique is that it would be better if you have done a plating and small grafting from ventral and add a posterior fixation or not. With an external orthosis, it could be without any posterior fixation. This is it is like ankylosing spondylitis. The patient is fused whole spine, almost all.
Okay, thank you.
Yeah, I think Mirza, and Mehmet, I totally agree that, if we get a case like that with somebody with hyperostosis, then probably the best thing is to fix it with a small graft. And obviously you would need a posterior fixation as well, maybe multiple levels, just to make sure that you have good quality fixation, because these patients obviously have a higher risk of complications.
Okay.
With the aging population, we are seeing such cases very often nowadays, especially in the developed countries, sorry. Also, elderly people are very much in those countries. And then we face with such problems very often. Thank you a lot for very nice, very interesting patient.
Thank you.
Cervical trauma. Now I want to invite a second talk from Dr. Aderain Haidara, a thoracolumbar trauma case. Mirza, can you please unshare?
Yes.
Thank you, Professor Ginelli. Let me share my...
Okay.
First, Mirza must unshare.
Okay.
Mirza, try to unshare, please.
Is it okay?
Mirza, yes, that's okay.
Dr.
Dr. Haidara, you can share now.
Okay.
Nice.
Okay. Thank you and good morning to everyone. Thank you for allowing me to participate to the WFNS Spine Committee Symposium on the management of spine trauma. Can you hear me, please?
Yes.
Yes, very nice.
Can you hear me?
Yes.
Okay. Today, I will present the cases and discuss on thoracolumbar spine. As you know, the thoracolumbar spine is the frequent site of spinal injury. It includes the less mobile spine segment of the thoracic to relatively hypermobile spinal segment of the lumbar spine with a transition zone. Most injuries occur in young males, specifically in Africa, with enormous economic loss, and most commonly thoracolumbar trauma as a result of motor vehicle accident in 50%, and in a few cases, fall from a feet. The most injuries occur between L1 in 52%, in L1 to L5 in 32%, and T1 and T2 in 16%. And associated injuries are common and may occur up to 50% patient. It concern thoracic and abdominal organ and great vessels, and non-contiguous spinal injury also in 5%. Our case is about a young 25 years young woman who is otherwise healthy. She had injury by car accident while she was traveling, and she presented with a normal consciousness, but the neurological exam showed motor and sensory loss below T6, corresponding to ASIA spinal cord injury, and associated with loss of bowel and bladder control. And she was admitted in our department one day after she made the trauma. So the initial CT scan showed a T7, T8 fracture dislocation with posterior ligament tooth complex injuries, and T8 vertebral displacement with spinal canal compromise with the presence of bone fragment inside and with segmental kyphosis. The MRI was not performed. So she had also associated injury, which was a bilateral pulmonary contusion and moderate pneumothorax, but she did not have respiratory distress. We decided to go for surgery. The choice was, the discussion was to choose the appropriate approach for the surgery, regard to anterior approach, posterior, or combined approach. We choose you choose the posterior approach with prone position. The patient was on two support, one on the chest and on the one on the chest and one on the pelvic. Yes. The surgery, during the surgery, we had the decompression of the canal spinal with tacit laminectomy, and we inserted 8 thoracic laminar hooks, medium size, in 2 levels above T5 and T6, and 2 levels below T8 and T9. And the two rods were secured in compression with to secure the hooks. And this allows the correction of the kyphosis. And in postoperative cause, the pneumothorax has been drained. There is no improvement in neurological deficit, will remain to ASIA, and the patient went to the physical therapy. The history control shown a good position of the hooks and a good position of the kyphosis, a good correction of the kyphosis. The pneumothorax has been drained after the surgery, and as here actually the follow-up is 3 years with no failure of the hooks. So it was the case I want to present. Thank you for your attention.
Dear Adere, very nice case actually, but young generation would not remember that hook systems. I have used many in the beginning of my career, but nowadays you'll see in many countries it is almost lost, and many people are using just pedicle screws. But good case really. I enjoyed it. You have make up a claws, so-called claws on the upper end and lower end. This is necessary. Yes. Otherwise, only distraction forces will not be good thing. Yeah. Salman?
Yeah, Mehmet, I think I really like the case, Durrami. Just like I think Mirza's case, this is also a very interesting case. The good thing about it is that, you know, we need to know that these are possibilities where we have limitations, where we don't have enough pedicle screws, etc. Otherwise, generally speaking, hooks have given so much grief to so many people that, you know, people have given up using them. But there is an art to it, and you use the art really nicely there. So if you were to use it, I think this was the right way of doing it, and you know, it's a beautiful execution of putting the hooks to ensure that they don't come out. The main problem used to be every time you used to bend with thoracic kyphosis or some kind of deformity, then obviously these hooks used to come out, and also sometimes they would cause pressure on the dorsal cord. And you know, it's unforgiving in that scenario. But I think it's very, very nice case. I'm grateful. Thank you. I really enjoyed it.
It's a reason why we use the medium size, because the hook is not big.
Good. One small critic for this case, Aderim. Yes. You have placed both downgoing and upgoing claws. Sublaminar, I think. You could try it pedicle.
Pedicular, yes.
Yeah.
Okay.
Yeah.
Yes, I know this technique, but we have laminar available, not pedicular.
This patient is paraplegic, no problem, but yes. In a normal neurology patient, you can have a spinal cord compression with laminar claws. So then it's better not to use them too much. You can try transverse process hooks or pedicle hooks. Yeah.
Okay.
Very nice, but it's available. Yes.
Thank you.
I think we came to the end of the.
I have some question, Professor Zilali.
Yeah.
I have some question to Professor Adelim and other speaker. This patient with hematothorax and pulmonary contusion. Is it urgent to do it earlier, the stabilization, or you have to wait a few days? What's your opinion, Dr. Adelim?
Yes, I think is the contusion and hemothorax, when there is some sign of distress, is urgent to manage early before the surgery. But in this case, the patient the saturation was good, and the patient was not distressed. So in the other case, we manage early the pulmonary problem before surgery.
Thank you.
This patient should not be operated in an emergency fashion because it is Asia A from the beginning. So then we don't expect, we can't predict he or she will recover neurologically. It shouldn't be emergency, right?
Mehmet, I actually disagree.
But in all the,
Sorry.
like I said in my presentation, a lot of Asia A patients do also improve. And because this patient was hemodynamically stable, even if he had hemothorax, one can put in a chest tube at the time of surgery.
In cervical spine, yes, because the eloquent nerve roots can be recovered. But in thoracic spine, with such a fracture dislocation, all dislocation, probably if he has done a MR image, he would see probably a torn spinal cord.
Yeah,
In cervical spine, you are right. We must do it in emergency patient, right?
I think, you know, every time I would suggest that we should try to do surgery as soon as possible, as long as it's safe environment. The best thing to do start out is you hypertense the patient. In this particular case, it is possible that spinal cord may be severely compromised, but we know that torn spinal cord, I've only seen once in my lifetime. So I think the chances of having a torn spinal cord is very, very, very small. There will be some residual there no matter what. So I think, you know, we need to try as soon as possible, but it has to be a safe environment. And the most important thing when the patient comes in is obviously your ABC. And then on top of it, you know, map to be above 80, 85. And even when you're operating, you're positioning, you should be after your anesthetist to ensure that the map remains at that stage in order to ensure that if there is a chance of recovery, it should remain.
One important thing, Salman, we must mention our participants that in first evaluation of the patient, Asia A and B can have very small differences. Actually, without a pinprick sensation examination around the anus, perianal area, you can't differentiate Asia A from Asia B. If there is any sensation over there with pinprick, then the patient will be Asia B, and you must be very, very early surgery. You must be doing that.
Yeah, I agree, Mehmet. What happens is if you're Asia A and if you have a cervical spinal cord injury and if you are aggressive, then 4% of those people will walk again. If you operate early and you hypertense them and you do all the necessary guidelines, you follow them.
Yeah. Right,
on the other hand, if it's Asia B, the improvement goes up to 20% of those people will walk again, even just with sensory perianal area.
Exactly.
And then if you go to Asia C, it goes up to 50%. So I think it's so important for us to be more aggressive with all kind of spinal cord injury, no matter if it's Asia A, you should try your best because you know some of them will walk again. So it is very, very essential. All having said that, you know, 25% of Asia A will improve, but we are talking about mobile. So, you know, with the help, that could be up to 4%. So, you know, it's important for us to be aggressive because those 4% are 4%. So we have to be aggressive.
Okay. I think we came to the end. I thank all the speakers for their great talks on this meeting. I thank Professor Nasser El-Gamdur for making that happen, and Salman Sharif, the chair of Spine Committee, and all the speakers, all the participants again. Thank you.
Thank you, Mehmet, very much
for joining us.
Salman, do you like to say any closing remarks before I close the webinar?
I think Mehmet has said everything. I'm grateful to everybody who's there, and I'm more grateful to all the participants who made this webinar fun. And it's good to see so many questions and amazing, both amazing cases that were shown by Mirza and Adirahimi. And all the lectures were brilliant. I learned loads. Every time I listen to these guys, I learn so much. I'm grateful. Thank you.
Thank you very much, Professor Salman Sharif, for this great opportunity. Thanks to all our speakers. Thanks, Mehmet Zilili. Actually, it was a very interesting discussion and the program was outstanding. And we will stop our webinars for 4 weeks. We come back on 14th January by a collaboration with Professor Louis Borba, Education Committee of the World Federation of Neurosurgical Societies. My best wishes to all of you to have a Merry Christmas and a Happy New Year. Thank you very much.
Thank you, everybody. Bye-bye.
Thank you. Thank you.
Thank you, Nasser.
Thank you, Salman.